and students and his colleagues alike. So we are really honored to have you here, sir. And without wasting any time, I think I'll just vacate the podium for sir.
Everybody, so morning you all witnessed must compliment Dr. Sushma, Dr. Gopalgiri, Dr. Vaishali and others involved in gathering all these cases and bringing it live was very wonderful. I'm sure you had good learning as to why hysteroscopy is the armamentarium of a gynecologist which cannot be overlooked. Okay, like we were resident, we were told as a gynecologist you should do PSPV. If you don't do PV, you don't go and operate or you don't do anything. And that was right, because if you don't do PS or PV, you are going to land up in complications. So that is a dictum which was taught and that still holds. If you don't do a PV and try to dilate, you are going to land up in complications. So today the things have changed, but PSPV still remains. But hysteroscopy comes into the same class where you cannot call yourself a gynecologist if you cannot do hysteroscopy. And that is very important. You will see why. Because it's our at home and see all this. Like last year we have related 15 live surgical conferences. Everyone was enjoying it at home. So the teaching has become easier. So the learning is becoming easier. So why are you all waiting? Even when I started 2.5 decades back, maybe 25 years back, when I started learning endoscopy, we used to travel, only one person in Bombay used to teach, and that also only just assisting or something. But today the world is open. You are all have so many teachers. You all learn through YouTube and everybody's Facebook and so many things. So you have to wake up and go, because we would not today we should not do blind and incomplete treatment. We ourselves have to be responsible for the best to women. And of course we had the liberty of, or the privilege of the operating here with Dr. Professor Betoki, who is considered the modern father of hysteroscopy. And because of his innovation, today all those instruments which you saw became so simple. Like before he brought this Betoki, we used to dilate, we had a round diagnostic sheet, and then we had a separate, only operative was with the resectoscope. So either you use resectoscope after using the dilatation and start this. But Betoki designed the whole thing, and you can see what he has done. And so we had a workshop with the AGL in our hospital about 5 years back, where we are around 60 delegates coming from all over the world, even Australia, Zimbabwe, South Africa, so many people, all were there. And Professor Bigatti, who's the one who invented the intrauterine morcellator, or called the Bigatti shaver, they were all there in the workshop at our hospital. So we were motivated that we have to match with them. Today, 20 years back, we would always think that a white-skinned person, European, is much better than we all. But we can match with them. So that's what your motivation has to come. Today nobody will say ki Indians are bad. Indians are excellent in endoscopic surgery. We have reached a stage, but we are not publishing, and that's why we don't get recognition. Now, just to talk about small anatomy of the uterine cavity, which is very important for safe hysteroscopy. What is the thickness? Which is the thickest part of the uterine body? And what is it? How much centimeter or millimeter? 1% loudly, yeah. Somebody said 1.5 centimeter. So one must know all these things. Lateral wall, the thickness is just 7 to 8 millimeter. Ostia is the thinnest, 4 millimeter. And what is the length of the uterine cavity? Normal, non-gravid uterine cavity in a nulliparous woman. Cavity is, yes, cavity is less, just 3 centimeter, 3.5 centimeter. What we are seeing in sonography is uterocervical length. Cervix is 3.5 centimeter, and we all call 6.5 centimeter, 7 centimeter. We forget that basic anatomy. What is the normal volume of uterine cavity? Non-gravid. 7 to 9 cc. That goes into the tube. Who does IUI here? How much, any of you do IUI, intrauterine insemination? How much volume you inject prepared semen? 0.5. Why are you injecting only 0.5? Put 5 ml of more sperms. Pregnancy will occur faster. Why are you putting only 0.5? Cavity volume in collapse state is only 0.5. Uterus cannot accept anything more than that. It will go into spasm. You will get pain. It will come out of the cervix, and patient will feel cerviviral. So 0.5 ml is the normal volume of uterine cavity, endometrial cavity. So this basic anatomy we all don't bother to learn. Today when I was asking the normal osmolality, normal this, we all fumble and then say this can create complication. But if you don't know the basics, how will you know it is creating complication? So learn all these simple things. So that is where the anatomy of the uterus hysteroscopy doesn't start from the internal os. It starts from the external os. Today you saw in that case where, last case where we could not see the internal os. So how can you say where is the internal os? But the cervical folds will always lead you to that point. So that is the, so the anatomy you should know from the external os, mucosal fold, internal os, and then the tubal ostia. And it's a triangle. uterus is always not like this, it's like this. So moment you know you have to create the cavity, you have to go laterally and it will come up, it will open up. So these simple things you should be aware when you're doing hysteroscopic surgery, because you're working within a 3 centimeter cavity. So your hand movements are very limited, very fine, you have to be gentle, you cannot have vigorous movement, because if you lift the endometrium you can't see. After dilatation you saw how difficult it was becoming to see. I just said that the innovation which all came, the smaller diameter hysteroscopes, right from 2 millimeter to 4 millimeter, we have the sheets of 4 millimeter which is used in ambulatory hysteroscopy or without energy and without dilatation, without anesthesia. And now today we have better energy applications. Like monopolar was the only thing 20 years back. Today we have bipolar, good current which is safer. You saw that bipolar is equally efficient. So all this has made hysteroscopy much more easier, safer. And what energy to use? Yes, scissors is always the best. Start off with the scissors and these graspers which you saw a couple of them, but occasionally these electrodes which you saw. The lower ones are the bipolar electrode, these are the return electrodes, these are the monopolar electrodes which didn't have the return electrode. The return electrode is the patient plate. And that is why monopolar always had more problem, but it was not the current which is problem. Monopolar current is good, but the media which we use for monopolar surgery in hysteroscopy is bad. Why? Because of the reasons I will again show you. So always start off with mechanical. Today 70% of the surgery or 80% of the surgery, operative hysteroscopy, is done by those simple 5 millimeter sheet and the 2 millimeter operative sheet, which all come with this all-in-one which you saw. Even if you want to dilate and do with a 7 millimeter, fine, but telescopes I have already said, and then only resectoscopy is required only in 20% of surgery cases today. Most of the thing you can do without energy. So the energy usage inside the uterine cavity, what happens? You perforate, you are touching the bowel, because bowel is surrounding the uterus all the time. You can't have that. So the moment you go into the serous and you have used current, it has already touched the bowel. Nothing can be done. So that's why scissors or mechanical instrument without energy, even if you perforate, you're not going to damage the intestine. You're just going to have a little bleeding. It's a 2 millimeter instrument, nothing. You just have to observe. So that is another advantage of using only non-energy current or non-energy methods in hysteroscopic surgery. Now, of course, hysteroscopy is the answer, you all know. Patients for infertility, patients with recurrent pregnancy loss, patients with abnormal uterine bleeding, patients with postmenopausal bleeding, patients with foreign bodies, and so many things. Hysteroscopy is the answer. So there is no reason why every gynecologist should not be doing it. And today the trolley has become only this much. We don't need all this. I was using this 20 years back, but last 15 years we are using only this trolley most of the time. Just these two tubings and a telescope with a sheath and these two grasper or thing, whatever. Most of the hysteroscopic surgery is a trolley. So this is what is modern hysteroscopy is all about. I wouldn't go into too much of a detail. I don't know if you will get bored if I go take your time. We all will be feeling sleepy. Now look at this particular slide. Very clearly established that this can be removed. They don't see this. My photo, they are seeing me now. Why want my image there again? Yeah. So you can see saline and ringer lactate plus as far as safety is concerned. Whereas glycine is one single plus. So why should we talk about glycine? Why? I'll come to that. You see the other slide where the electrolyte content of saline and ringer lactate is there. Glycine is an electrolyte free solution. Osmolality, you can see, you can see the osmolality there. It is 200, whereas normal saline, I was trying to tell today, it is between 275 and 308. So the blood osmolality is around 285. So that means what? Even if the two fluids are together, there is no osmolality difference. If you go back to our physics study, hyperosmolar solution goes into the isosmolar solution and they come back into balance. So if you use two solutions, one which is isosmolar, cells are going to get edematous. So glycine is bad in that way. Glycine has no electrolyte. if you put 1 liter into the body, electrolyte drops. What is the normal sodium content of human body? Yeah, 134, 135. Our pH electrolyte is important for us to be like this. If a physiology gets disturbed, nothing can be done. So if you change the electrolyte content, 1 liter of glycine, if it goes, sodium drops to 125 by 10. So cells cannot function. If pH varies, cells cannot function. So you can't do anything. So you have no reason to change the human physiology. Whereas hysteroscopic surgery changes all this physiology because of its nature of surgery. Because you have to use pressure. Urologist, the bladder is a distensible organ. It can accommodate 1 liter of water without any problem and it fills slowly. But uterus, you have to give pressure to expand it. 45 millimeter is required to distend the cavity to C. At 70 millimeter, the tubes open up and the fluid goes out. And the mean arterial pressure is 95 or 100. So if you have distension more, it goes into the blood vessels. So if these things you remain in your background, you will not create complication. Otherwise, hysteroscopic surgery, when it started 20 years back, people had unexplained death. Suddenly, karte, she died. So air embolism, fluid overload. So how can you use this? And glycine has more complication. Glycine is metabolized in the body as what? The end point product is ammonia. So you have glycine causing no osmolality, no electrolyte, that is there, but it goes into ammonia. Patient goes into hyperammonemia stage. And hyperammonemia can cause encephalopathy and permanent brain damage. And not only that, it causes retinal signals to be blocked. Patients, sometime after coming out in days, I have seen they are blind. They say, I can't see anything. So can you have a young patient of 25 coming and the relatives will just thrash you out? They become blind. Though it is temporary, but almost 48 hours to 72 hours patients are unable to see. So with this kind of complication, why are you talking about glycine? You cannot talk. You have to be very, very safe for the patient. So this explains which media is to be used today. It is only ringer lactate or saline. Now, I will just show you. I was of course demonstrating in this morning. You follow the mucosal fold, it will exactly lead you there. Can you see? I call it as the gem point or getting entry methodically. So in these cases where the internal os is closed, here you can see a tuberculous cases, even the flattened mucosal fold will tell you. So in that case, the last case, you can imagine it was almost like this. You know that there is nothing, but that is how you know entry correctly, you enter in the right plane. So that anatomy hysteroscopic, you should be very, very confident. Now, hysteroscopy for polyps. So I'll just go into some of these which you already seen today. Maybe some will be repeated, but if you don't want to see videos, you can always tell. We can always have discussion. But this topic is just prepared currently. What are the things we do operatively? Now you saw me using scissors in the morning like this, where you can occasionally use electrodes, but even 2 millimeter bipolar needle and monopolar needles are available. They can go if the scissor is not working. But as you see today, even with that difficult polyp, we could manage removing it hysteroscopically by the scissors. So this is again a postmenopausal uterus. You can see flattened endometrium, but a single tongue-shaped polyp coming out, and you just remain very close to the base. Take your time and see how to beautifully cut it there. Though hysteroscopic, if you had a separate hand, you would have just plucked it like this and cut it. Where you to do in laparoscopy, in open or in a laparoscopy. Whereas hysteroscopy, it is not possible. And after removing the polyp, you can see this grasper you should have, and then remove it. Well, fibroid is something which is, you didn't see today, but definitely fibroid you have to know how to remove, because most of the complication in hysteroscopic surgery is after submucous or transcervical resection of myoma. Now this, on this side you have a single posterior wall fibroid, and on this side you have two fibroids opposing each other. Now posterior wall fibroid is always much easier to do. If at all, this is a type O fibroid which is projecting totally into the uterine cavity, very simple, because everything is just looking like a laddu there, you just have to cut it. Whereas if you have opposing side fibroid, anterior wall fibroid is more difficult because you need to turn your loop upside down and you have to cut the roof, whereas this is becoming easier. So if you are doing a fibroid for the first time, if you have the posterior wall fibroid, it is much easier. And the loop of a 9 millimeter resectoscope has a depth of 4 millimeter. So you dig more, you might get 1 or 2 millimeter more. So a 4 centimeter fibroid, 4 millimeter means you have to dig 10 times. So the time taken is more. Any surgery, time taken in the hysteroscopy is more, fluid overload will occur. And that too in a submucous fibroid, when the vessels start opening up and your pressure is more, fluid goes. So initial part of the surgery, the pressure or the fluid, for the first 10 minutes your fluid may be just 2 liters. But the next 5 minutes you will lose 2 liters because the vessels have opened up and you are pushing blood, fluid into the thing. And the end point is, of course, you can see, you will be able to know the transverse pink circular fibers of the normal myometrium. This capsule of the fibroid you can appreciate is more whitish, and as you go down you will start seeing the normal myometrium. So when you are having opposing fibroid, you have a chance of adhesion formation because opposing walls can get adherent because of the raw surface. So here you can see as you go closer to the endometrium, you will remain little superficial, because in a nulliparous patient or a patient who is for reproduction, you can see that pink fibers there. These are normal myometrium, and then the capsule you can still identify more fibroid is there. Cut it. But hysteroscopic surgery, another advantage is always there is a second day. Unlike in your open surgery or laparoscopic surgery, you can't cut the uterus half and leave it and say, Ki, I cannot do because of complication, tomorrow we'll come and do it. It's not possible. Whereas hysteroscopic surgery, you can leave it. Half septum you have cut done half Asherman or done submucous fibroid half, you leave it and do it on another day, which is not possible in any other surgery. That is the other advantage. So if there is a complication or if instrument is not working, you just leave it and tell the patient some excuse and do it after 1 week. And that is the advantage of hysteroscopic surgery. So why create complication? So the moment fluid overload occurs, stop the surgery, do it in a second sitting. Don't charge the patient at all, because you have to convince the patient. If you are convinced, yes, no problem, anesthetist has to just give anesthesia. So that charge you may take, but it is very simple. So that is where hysteroscopic surgery is something which is very simple, easy to learn, because you can learn the next day. Today I don't do, but tomorrow I can complete it. So that is where hysteroscopic surgery I would recommend all of you should do. Whereas you can see this is a difficult fibroid. Now what you saw was a type O fibroid, whereas what you see in this is a lateral wall fibroid, type 2 fibroid. But this is as per the Lasmar classification. There is the ESG classification of 0, 1, 2 is different. Whereas Lasmar classification, you can see it takes into account even the lateral extension into the myometrium. Once there is lateral, it is going into 2. Score of 2 is added. And as per Lasmar, more than 5 is a little complicated, should not be done by a beginner. This is a Lasmar 8 which you are seeing there, where you can see that it is extending into the lateral wall, we thought, but it is actually extending into the anterior wall, posterior wall, and it is elongated like this. So it is going to take more time. So this cannot be attempted by somebody who is a beginner. You will land in more complication. So you have to counsel this patient that we may have to do in 2 sittings. Otherwise, do it by laparoscopy. Now this fibroid, what you are seeing in this, even I have never seen this type of a case. This is global fibromatosis. Every millimeter of the endometrium is studded with fibroid, from small to large. She was just 28-year-old, she was for infertility, but she had so much bleeding that hemoglobin never rose above 4, and she was referred from Lucknow. And the day when I had to give her 2 blood, and next day we operated, we removed 17 fibroid. But then looking into this cavity, I said I cannot remove all, it is impossible. So after another 2 months, we again called her from Lucknow, again removed another 21 fibroid. But at least pregnancy cannot be promised to her. But at least she is happy, her menorrhagia is controlled, her uterus is intact, her in-laws are not angry with her कि uterus ही नहीं है. So at least her uterus is there. So this is now you can see after ulipristal therapy which was available that day or luprolide also, see the vascularity is diminished so much. There is no bleeding. So that is again an advantage where you want to reduce the size of the fibroid or you can't do it on that day. Give luprolide for 2 months. Fibroid, submucous fibroid, the hemoglobin builds up. You can do the resection much better or easier. Yeah, this is welcome. So this is a global fibromatosis. Of course, this should not be attempted by everybody. The less than last mark 5 is all what is fibroid. So as a beginner, one shouldn't do fibroid myomectomy initially. You can do 2-3 resection and then leave it and do it next day. But start off with polyp, start off with septum, which are simpler. Get used to the cannulation, which is again simpler. So your hand movements within the uterus is very coordinated. So these are things which you should start and then go gradually to more difficult surgeries. Now, morcellators are available now. This is, of course, resectoscope. We all in India continue to use this because morcellation comes with extra money. But those who are using it say that it is better because it is faster, because the tissues don't float inside the cavity. It is sucked by the fluid. So today you saw even the TCRE, those pieces were coming. So you have to take care of them and then continue. And more the time you remove the resectoscope outside and again go in, you have blood again. Uterus lining will bleed the moment you even distend it. So the next time you go, you get more blood, more debris. So take more time because you have to push more fluid, more suction. So these morcellator are good for endometrium damage, not there. They are supposed to be faster and they don't damage the endometrium. Whereas current we don't know can damage the endometrium. So patients who are for IVF or infertility treatment, they say this may be better. But most of them, the studies showed that still submucous fibroid people continue to use the world over resectoscope because they are comfortable and maybe monetary consideration could be a reason. Well, intrauterine adhesion, I just told you, we are the people who are responsible for intrauterine adhesion. It doesn't come on its own excepting tuberculosis. That is the only condition which can cause. Otherwise, all of us have created intrauterine adhesion, and with hysteroscopic surgery, we thought it will be less. But you can see submucous fibroid causes 45% chances if there are two opposing fibroid or multiple fibroid. Even myomectomy can cause laparoscopic. So adhesions have increased. So you need to know how to pick it up. You need to know why hysteroscopic, why Asherman should occur. This is what I was trying to talk to Dr. Vaishali today. You can see on the other side, stop doing DNC for retained products of conception. Do it under hysteroscopic control. See, the product is usually in one corner. And it is just adherent. It won't come out with your misoprostol and other things. What you need is just those grasper or Caesar, separate it and just remove it. The rest of the endometrium doesn't have any chorionic tissue. So why curette? But when you do blindly, you sit and curette the whole. And next time you don't want the patient to again, sir, aapne aadha kaam kiya. So you try to do more and more vigorous curettage. You don't know where it is and you curette all the corner. Where under vision, you can see where it is and then remove it absolutely simply, easily. So, and even if Asherman does occur, why it should become serious or severe? Pick up early. Understand, the moment you pick it up early, you know that the adhesions will separate very easily because the endometrial layer is not yet become fibrosed. It will break with your distending fluid itself and it will just break. See, it is breaking with the pressure. These are early Asherman. So after a DNC, if a patient comes with oligomenorrhea or amenorrhea, you just put in that hysteroscope and distend it, it will break. Understood? So that is why Asherman should become severe. Well, if it becomes severe, what happens is, this patient post vesicular mole treatment 2 times DNC. Vesicular mole, we are always taught that do repeat DNC so that no chorionic tissue, so gestational trophoblastic tumor will come. So we always do 2 times DNC just to make sure. And this is caused what? Total adhesion. Internal loss not seen. And there again I said the Caesars is the simple answer. Don't dilate because dilatation will just give you a tubular fibrotic canal and you won't know where you are. Whereas under vision, you can see how beautifully this scissors is opening the cavity for you, but the gynecologist who did the DNC didn't do damage, as much damage as the last case which we saw, so much fibrotic. So it's of course individually patient based. Dr. Gopal Gray was telling, yes, the more accurate it is there, sometimes individual patient's propensity is there to develop severe adhesion. But you need to know that you follow the mucosal fold, open up the scissors, just dilate whenever required, take your time, don't be in a hurry, just open up and you will go into the correct plane. See that? So this fibers, today you can see that it was much more easier to cut, whereas some of today what the second patient was more fibrotic. So definitely remaining in the plane is important and remain in the midline. And you can see you are going in the right plane. You don't have to be afraid of perforating or going in the wrong plane, because cutting a muscle is not that simple like what you are seeing here in the endometrium. You can see the endometrium is opening up, cavity is opening up, and then gradually push your sheath inside and you will see more, and as you go up you can start seeing that you are in the right plane. If you are perforated, the fluid will go out of the uterine cavity, distension will not be there, and you can see that the cavity is a triangle, inverted triangle, and laterally also you have to cut, and as you go up you start seeing the fundus, you start seeing the ostia. So this is traumatic assurement, but luckily not global. There was damage, but patient did have some amount of menstruation, and that's why the endometrial cavity is still easily accessible, though there was complete adhesion. And you could create the cavity, the endometrium is seen, and these patients, you have to do a relook hysteroscopy. The time to do relook hysteroscopy has been told, that recent papers say that within 15 days you do, because these will again adhesion form, and that time you go, the adhesions are flimsy, you cut it, rather than waiting for 3 months. So this is a patient who has had, of course, these patients who have severe assurement have a pregnancy rate just close to 25 to 40%, whereas early assurement, they have close to 85-90%. So it is better that we pick up early and not wait. After DNC, our patients come back to us. After the DNC, oligomenorrhea is there, or amenorrhea is there. So you have to think, don't do that FSH, prolactin and TSH, and so many investigation people do, just wasting time and nothing happens to the patient and it becomes more and more severe. So this is, you can see the cavity is very well created. So this patient will do well, at least her menstruation will improve, and if the Doppler shows good vascularity, she can have a good chance of conception. But creating the cavities are responsibility, knowing the anatomy. See, you can see the beautiful size, shape, everything after a total global assurement. You can see the one ostia there. Don't run after the ostia. Even if you don't see, it's not a problem. Second sitting, you will always see. Well, abnormal uterine bleeding. That is another big issue. Today somebody was asking, should we do directly DNC? But today you can see all these various pictures of malignancy. You will see in a abnormal uterine bleeding, whenever you think it could be malignancy or postmenopausal bleeding, you can see various types of adenocarcinoma. In the lower one you are seeing tentacle-like structures, which is classical of adenocarcinoma. And there you can see other way of presentation, shabby endometrium, necrotic polyps, and there also you can see all these are very classical. And how to take biopsy, I did show you. You pick up a good tissue with your grasper and then bring it out without, not bringing into the sheath, the whole system out. You cut it with scissors if required to have a bigger chunk, and then bring it out and take it biopsy. So hysteroscopic guided biopsy has to be done in patients who have suspicion of malignancy, and doing hysteroscopy doesn't harm the patient. Studies haven't shown that even if the cells are there in the peritoneal fluid, they don't get nidation for it to grow. So there is no extra morbidity, or long-term survival rates have been similar. But try to keep the pressure low. How much pressure you will keep? Intrauterine? 70. At 70 it opens up. So keep it low. Understand? So this, everything should be there in the back of your mind. I am doing this patient, so I will do this way. So this is a medical college, so you won't miss your professor. I keep asking question. Hysteroscopy in patients who do not want their hymen to be disturbed. Now we get lot of patients at 17, 18 or unmarried, chronic leukorrhea. They say, pani aate rehta hai, what to do? So you can't put in a speculum and see, you are also afraid. So you put in your scope, 4 millimeter scope inside the vagina with the mother standing in the office or in the OPD. You can see ectropion. Can you see the ectropion here? So you can demonstrate, this is the reason, so nothing is wrong. I can even cauterize it with that bipolar resectoscope cylinder inside the OPD. So this is something which is so easy, so simple, rather than putting a speculum which you don't want to put in a patient who is not married or not sexually active, not agreeing. And 17, 18-year-old mother is always sitting. Whenever you take a patient, and mother also walks in with her. So you have to make her stand, show her the video. She is also thrilled, and you get in front of her, do the quadri. Such wonderful. So she'll pay you extra and go. Don't worry. Understand? So this you have to do. So all these things, if you don't have, you can't say ki paisa nahi aayega. See, most of the beginners say ki how to put in money, paisa aayega nahi na. But unless you put in money, you won't be able to do everything what you want, and confidence grows. Patient will definitely appreciate it, and money comes. And this is another beautiful patient of 31 but unmarried, had bleeding, bleeding, bleeding. You can see 6 months she was having bleeding. Sonography was suggesting that inside the cervical canal there is a mass, and the uterine cavity was normal. You can see we went into the cavity. You can see the upper part of the cavity clean. The whole mass is in the cervical canal. But the appearance did tell me that it doesn't look normal. There are tentacles which I just showed you. It was like malignancy. And the report came as carcinoma in situ. Adenocarcinoma in the cervix. You can see the tentacles. But MRI done, muscle is normal. There is no penetration. So this patient at 31 had an adenocarcinoma which could be removed with that Gubini resectoscope without opening the vagina, without opening the cervix. You could just go and remove the whole thing. And she is now being followed for almost 2.5 years. She is cancer free. She is given high dose progesterone. So you can follow them up. Repeat pap smear every now and then. But you can see the whole cavity or the whole canal we resected. It was all in the canal. So working inside the canal becomes difficult because you don't get distension. Fluid starts coming. Yeah, we welcome the IAG secretary here. He just come, Dr. Atul Ganatra. Please come, please come. He had trouble leaving because he had emergency and he had some traffic at the guards. Otherwise he would have, or rather I would have allowed him to be in the operation theatre. Welcome. He is the present General Secretary of the Indian Association of Gynecological Endoscopists. So this is all beauty of operative hysteroscopy. So applications is not only between 30 and 45. Application of hysteroscopy is even for 16, 18-year-old girls. And today, women are living more aged. The scope of people are living long now. People at 75, 85, 80 also, everybody is energetic. Women are also living at 80. So the problems with the women becomes different. Body grows, but then there are complications related to the uterus even at that age. So you have postmenopausal bleeding, you have abnormal thickness of the endometrium, you have fluid, somebody has forgotten the foreign body. So we get a lot of patients who are on pyometra, such a big problem at this age. Because the cervix is closed and the fluid starts collecting and you get pyometra. So they also come for hysteroscopy, and in postmenopausal patient the cervix is inaccessible because the lip is very small, it is pinpoint, you can't hold it with the cervix, with the valsalum, try to dilate, the valsalum keeps slipping and it's a nightmare. So patients, when they come with that problem, what are you going to do? You have to give them answer. Now the largest polyp I have ever seen was in a postmenopausal 74-year-old. It was 5.5 centimeter polyp in a postmenopausal patient. But looking at the other where you can see the cervix is totally stenosed. Here, you dilate under vision. You just, there is hardly any cervix seen, but you put in that grasper 2 millimeter or use that scissors, and you can see that 5 centimeter polyp there, totally occupying the whole of cavity. And then now you enter here, Now that is simple job. You don't put in a resectoscope, remove it, and it looks non-malignant because though vascularity is there, it's a very healthy tissue. So the patient is saved of that anxiety of removal of uterus, malignancy is ruled out, and here you can see multiple small polyps only in this patient who had postmenopausal bleeding, but even dilatation. So blind dilatation would have led you nowhere. So under vision at postmenopausal 75 and 80 is all possible because of the innovation in the instruments. So you need to have all these instruments. You cannot give a good answer if you don't have most of these things. Well, this was another patient referred to us, 2 previous LSCS, had menopausal bleeding, DNC attempted but abandoned because could not even see the cervix. But you don't have to see the cervix to do DNC. Okay. See this. Where is the cervix? Can you see that pinpoint? It's just with the vagina. It's a small hole. But the fluid inside the vagina showed you that there is a small outlet. So that means that is the cervix. And you can see the mucosal glands there. This is external os. So you can see the mucosal gland. It was just so simple to enter with that 4 millimeter sheath. So what she had was very simple. Again just a polyp, non-malignant. See that. Nice, beautifully grape-like, hanging, just a benign looking polyp. The rest of the endometrium is flat as in an atrophic endometrium, and all you need is that simple magic wand scissors, which is just 2 millimeter. So it is so simple, and this patient had come from Kerala because her daughter said somebody does hysteroscopy, go there. So in Kerala it was abandoned, we could complete it, and you are happy that you have done something different which others can't do. So even if the patient doesn't pay you, are still happy. But this patient you can charge more, the other one has abandoned it and you can charge more. So it is so simple, so learn hysteroscopy. I have shown you all the advantages of learning or mastering hysteroscopy. How to grasp a polyp is shown in this. This is a single long polyp, it will come out easily, but all polyps you cannot remove like this, you have to reduce their size, otherwise it will escape. So you can get the whole polyp in toto. Pyometra. Again a very common problem. Another 70-year-old lady had pyometra. 2-3 times somebody did DNC, they could not see anything. But what was MRI was showing a tubular mass next to the cervix, which was 4.5 millimeter, 4.5 centimeter. So some fluid collection in the apex of the vagina, it was reported. But when we entered, to our surprise, we saw 2 cervix like what you saw today. So this patient already has 2-3 kids. She must have not been told that she has bicornuate uterus. So the other os was not seen, but you can see the hysteroscopic fluid allowed you to see that there is an opening there. So we entered there and pus was there. So which MRI reported as a fluid collection in the apex of the vagina, it was the uterus. So again this is, see the pus, you can see the pus draining out. And of course, these patients, you have to rule out malignancy. Almost 35% of these pyometra patients will have malignancy. But looking at the cavity, you can say that the endometrium is quite healthy. You can take biopsy if you think there is some abnormal area. And give high dose antibiotic, keep that os open by putting in a catheter for say 5 days. And the patient still occasionally once in a year or sometime comes and say, ki, beta bahut kush hu. And so they are so happy because that discharge keeps bothering you. And that's a purulent discharge. And the gentle side of resectoscopy, which we were showing today, 26 and 22, but we have the availability of these 5.5 and 6 millimeter, where you can see you can enter without holding the cervix. Can you see that? No dilatation. You can just walk in with the electrode inside the sheath and you can resect any polyp. All postmenopausal patients, this was of course the doctor's mother, but you can see you can remove them. So using a loop is now a child's play. Only thing, you didn't have a good instrument to enter. If you have a 9 millimeter, it will maybe difficult in these cases. If you have a smaller resectoscope, it becomes much easier. So this is a 5.5 millimeter resectoscope. You just resect. So this is what we couldn't show. I showed you polypectomy with the scissors. Submucous fibroid is done similarly. You saw the previous slides, and you can just all these are benign looking polyps. So there is no evidence of malignancy in both these polyps. So all these patients would not require hysterectomy. They just require this and send it for biopsy. So this takes a little more time because the loop is smaller, but definitely it is worth it. So this is the gentle side, because to dilate it would be more blood, more hemorrhage, more time. But again, go on cutting it till the end. So in postmenopausal patient, you are not bothered about damage to the adjacent endometrium or patient with abnormal uterine bleeding. But patients who are young and who are for IVF or infertility treatment, you are not supposed to touch the adjacent endometrium with cautery or with current. Use it less, though we don't know whether they will really cause, but why to use. But other patients who are for AOB, some amount of damage to the endometrium is welcome because the bleeding will be less. So this is how you continue to cut. Cutting a polyp is much easier than cutting a myoma or a fibroid. So one should buy. If you think you want to master, one should go for buying this smaller diameter resectoscope. Well, adapt to the evidence. The world does ambulatory hysteroscopy. I don't know who all watched the GEM hysteroscopy last year when it conducted. We had Professor Betoki, demonstrating submucous myoma without anesthesia, Professor Attilio. So here we are doing a polyp. You can see that Gubini resectoscope going in. The patient is awake, patient is talking, patient is awake. She doesn't mind a little bit of discomfort. So anxiety is the one thing which most of our patients, the moment you say I'm going to operate, they feel pain and they are not ready. So the anxiety causes more problem than the procedure itself. So yeah, even the lithotomy. So you have to counsel them, but we all have to start doing maybe ambulatory hysteroscopy in another decade or so. Patients will demand it. You may not do extensive procedure, but you cannot compromise on the instruments. You cannot, just because it's OPD, you cannot say I'll have this. But you can take them into your OR, but don't give them anesthesia. Do it where everything is there. So we occasionally do in the OR or in the OPD, depending on the energy required, because you can't have two cauteries, two endomat, one in the OPD, one in the OT. It becomes difficult cost-wise. But in India, because the consideration are different, any OPD procedure, and you can't even charge 1,000 or 2,000. Forget about 10,000 or 15,000. Nobody will give. They say he's just making a fool of us. So these are things where, but there are people who do a lot of ambulatory hysteroscopy in India also have started. We also do. But yes, you all have to pick up. You have to be very careful about these procedural complications. Vasovagal reaction can occur. Local anesthetic if you give toxicity. Perforation can occur. Even so in OPD if you have, there will be chaos. So you have to be very careful on all these counts. Well, today hysteroscopy is the stethoscope for every gynecology. Should be doing it. Women deserve the best. Nothing, and uterus ko bachao. So I'm sure you will all agree with me that you can't do unnecessary hysterectomy when hysteroscopy is available, and you as a gynecologist cannot be half-baked. You have to be complete gynecologist, confident and motivated. So to accomplish new things, we must not only foresee but also act. So unless you all just come and watch in a conference, and then don't act, don't go and do it, you are also not going to become master. So tomorrow pick up the hysteroscope, pick up a scissor and start working inside the uterine cavity. And working in the uterine cavities, as I already told, we all know how uterine cavity should be. We have spent 270 days there. Why are we so scared? Respect it, you will succeed. So this is just a part of the course we are having. Gynec endoscopist, we have started courses in India where the fellowship certificate is going to be given by AGL with selected centers of various topics. So our center at JK Women is for focused hysteroscopy. So we are having the first course between June 2 to 5, where 2 days live surgery, 1 day interactive session. Even, of course, foreign faculty will be joining via the Zoom, and they'll be giving lectures, and 2 days, and then there'll be hystero trainers. So it's going to be focused 4 days of teaching. So anybody interested to become a hysteroscopy guru are welcome. Thank you for patient hearing.
Thank you so much, sir. You can please be seated while I'm sure there are lots of questions which the audience has, because we've really put you to task since the morning with the operatives. So you may please sit and answer, sir. Or are there questions for sir? Yes. Here starts the first one. Please introduce yourself. So you have a question from this young lady.
Yeah, definitely. I'll answer.
Good evening, sir. I'm Dr. Sandhya.
Yeah.
Sir, hysteroscopy, is there any specific format for reporting hysteroscopy?
Report, yeah, definitely. As I said, of course, indication is definitely there. And then you have to write what distending media you used, what are the pressure used, what are the fluid used, how much is the deficit. So this is as far as the fluid. And then anatomical description, you start from vagina. Vagina, external os, cervical canal, internal os, then the cavity, whether the normal anatomy was seen or there are pathologies, which could be so many things which we said. So this basic reporting should be there, but definitely fluid deficit should be mentioned in every hysteroscopic patient.
Thank you, sir.
Anybody else has a question? Yes? Are there any questions for sir? Yes, Dr. Pankaj.
Good afternoon, sir. I'm Dr. Pankaj. Marvelous and excellent work. A basic question on hysteroscopy for removal of incomplete the products in incomplete abortion. Anything about the internal os is supposed to be sterile, and when we have bleeding in incomplete abortion with the flora of the vagina, maybe colonization, maybe ascending infection, how good or how bad would it be to do hysteroscopically to remove the products? And same thing in cases of leukorrhea. Suppose we do a hysteroscopy, is it going to cause PIDs, chronic PIDs, etc.?
Yeah, even if you have to remove retained products, you are going to go through the vagina only, dilate it. So anyway, we have to clean it with a good amount of betadine, which we all do. And in fact, if you look at the way the hysteroscopy is done ambulatory, I was shocked to see when Betoki or Sergio, they don't even wash up. They don't even clean the vagina, because they say the moment you touch the vagina with an instrument or a cotton or a swab it, the patient is uncomfortable. Yes. So they all do hysteroscopy without any asepsis, without any cleaning with antiseptic solution. So the vaginal flora, which is normal, is a normal flora. It is not going to cause PID. Patient has a vaginal infection, you treat the infection and then you do the hysteroscopy, that is taken care. But normal vaginal flora is not going to cause PID. Every woman has some amount of vaginal flora which is required for the maintaining pH and preventing the other organism from coming. Patients who get recurrent leukorrhea because of candid or trichomonal or bacterial, they all have altered pH and the flora is altered. So in a normal woman, nothing happens, no chance of your infection going up. And as such, we all do DNC. No? So it is the same. Here we are actually doing the same. You are not pushing the fluid from the vagina into the uterine cavity. So I don't think there is any incidence of increased infection, because when I saw these people doing without anything, even I was amazed that infection is not occurring even for them.
Okay. Anybody else has a question for sir? Yes. Any more questions?
Sir, when can we do, if the patient is bleeding, is it safe to do hysteroscopy?
No, it is definitely safe. Only thing, your visibility will be poor. If the bleeding is copious, you have to spend time to get it washed. So less amount of bleeding will make your procedure fast, and if there is hyperplasia of endometrium, again hysteroscopy is going to be difficult because you cannot really see. But just to rule out malignancy or a large polyp, you can put in an hysteroscope when the patient is bleeding. But yes, you just need little more time. You need to have the suction attached and get the fluid out, and it does become, with maybe 1 liter more extra you will be using.
Anybody else has a question? Yes.
Hello sir, I'm Dr. Suhas Gaikwad. Sir, my question is, what do you counsel exactly when you do an hysteroscopy for a patient whose DNC was done by you only?
When you have Asherman, you mean?
Yeah, if you have done a DNC and you
the retained products you mean, or for Asherman?
No, both questions.
Yeah, yeah.
Once, if I have done a DNC,
Right.
and then she comes with oligo, okay, or less flow, and then you said that you put a scope. What exactly should I counsel her?
Correct.
What should be the words I use?
Right. Now you should always first tell the DNC is a blind procedure. I'm not seeing what is happening inside. You can ask somebody to stay at your door and clean your room. It's not going to be possible, even if you give the biggest of broom. So that way you keep. And complication, if you can always tell them, see, it's a blind treatment. If I've left a small retained products, if I'm more vigorous, it can cause perforation. It can cause more problem. So that is where some small piece can be left behind, and that is acceptable. The patients always don't fight with you for arguing and telling that that is possible, because it's a blind procedure. Now when you have Asherman, yes, it's something difficult to answer, but again you can jolly well explain them that your body has got a tendency to get adherent, and the normal uterine wall is one against each other. So after a procedure, maybe the raw surface and the blood just made them help each other. And here I have diagnosed you early, so I am giving you the remedy. So it becomes, if you are, most of the time we shouldn't hide from the patient initially. The more you hide the complication and they come to know later, then they will jump on you. And they know today you cannot hide anything from your patient, because they can immediately see the Google or why adhesion occur or what is. So they will always, if this was possible, why you didn't tell me? But if you have told them, they accept it.
Sir, many other times after doing DNC, we send a patient for home, and after 1 week or 21 days, we call him. Then our fellow radiologist give an ultrasound saying that it's an RPOC.
Correct.
So what is the size you say that we should go and intervene? At times they write that RPOC is 1.2 into 2. What is there any?
No, RPOC, I would say, see, anything RPOC, it's a real RPOC. It is going to cause some amount of infection, some amount of bleeding, some amount of spotting. So if any RPOC is more than 0.8 millimeter or 0.5 centimeter, I would go and remove it. I wouldn't leave it, because infection chance is there. Patient will have all the time. Yeah, please, yeah.
First of all, from your dictionary, remove the word C. Never write curettage. I have not used a uterine curette in the last 20 years of my practice. You will use the word suction evacuation. Today, every patient reads Google. If you use the word curettage, evidence will show that the curettage can cause adhesions. Using an MBS syringe or an electric suction, I'm a great proponent of the MBS syringe, because when I was the chairperson of the MTP committee, we started the MBS syringe with Dr. Nozar and Jaideep. So don't use the word curettage in your discharge summary. I have gone to court 4 times. I have even gone to High Court, but we will discuss all this on another platform. This is an endoscopy platform. And if it is a post-medical abortion, retained products of conception, more than 15 millimeters, you need to evacuate. If it is less than 15, it will come out on its own. Just give antibiotics or doxycycline. I can show you 500 cases of that. So please do not use the word curettage. From tomorrow, in your discharge summary, no curettage, and there should be no curette on your table.
DNC.
Unless you're doing a gynec DNC.
Okay.
Okay, gynec DNC for menorrhagia, where you want to curate more and you want that damn uterus to get stuck so she stops bleeding. But in a patient with reproductive age group who desires fertility, do not use a curette. And do not write curette.
Okay.
So other controversy, like if you are suspecting CA endometrium, in that case, doing hysteroscopy is justified? Even if you are
100%
suspecting, and is
justified.
there anything
Yeah,
like
no, that's what I was talking when you didn't, you were not there. I was showing all the slides of the endometrium. Studies have very clearly shown that the malignancy doesn't big
Yes.
worsen, nor the morbidity, nor the long-term survival. They have found the malignant cells in the peritoneal fluid. It is going to go, but those malignant cells don't get nidation to grow there. Understand? So that is where the mortality or the morbidity doesn't increase. So definitely you are justified, but yes, you have to keep a lower pressure. Don't try to push too much of fluid into the cavity. If you are able to see, pluck out those biopsy kili and nothing happens. When we do it routinely, and definitely if you do a blind DNC and you miss out a malignancy, you are not going to protect it. You cannot say, okay, I did a DNC and that's why I missed it. No, you're not supposed to miss it. So hysteroscopy is justified.
And polypoidal lesion will be missed. You will not get a polypoidal lesion at hysteroscopy. It's like closing your eyes and trying to clean a vessel. You will never get the entire material out. You must do a hysteroscopy. We must be doing, in fact, just last month we were discussing that suddenly we've had too many cases of CA endometrium. He had 4 cases in the last month. I've had 6 cases in the last 1 month. And on one occasion, this patient of mine, which we just did a radical lap hysterectomy, the polyp was malignant. The endometrium was not. And she just had 2 or 3 polyps near the cornu, and he will also agree that removing it from the cornu becomes a little difficult.
Yes,
so you have to actually go and resect it from there. And if I had to miss that out, you would miss that in a DNC. If you miss that out, the patient is going to land up with a complication. So you must today, I don't think there is any room to do a gynec DNC. Nobody should do a gynec DNC. Just not allowed. I think you will miss findings.
No, obstetric DNC was always banned, already banned because the availability of M+M. So he said the bread and butter has to be forgotten and hysteroscopy should be the cream and cake.
Wow. So wonderful questions and answered like the real masters that they are, with no dilemma or no gray areas. So this is what a master class should be, isn't it? With the masters giving you very clear-cut, precise answers. So if anybody has any more questions? Yes? So
Thank you.
thank you so much, sir, and we look forward to our next speaker, Dr. Atul Ganatra, who's a director at Ganatra Nursing Home. So I won't take up much of sir's time. Suffice to say that he's the secretary IAGE for this year.
Make it in time, and thank you very much for inviting us here, and please all of you all become members of IAG. It's a wonderful platform where you will honestly get to learn a lot, and purpose is to teach hysteroscopy, because not if 500 people do laparoscopy, only 50 people do hysteroscopy. And trust me, hysteroscopy is extremely simple. You just have to get the right instruments and get the right teacher. And I think who better than Krishna Kumar today, a kind of internationally renowned figure in hysteroscopy training. And you must get, your own scopes, you must get your own resectoscopes and sheets, and only then you can learn hysteroscopy. Nobody can teach you hysteroscopy. I also have as many scopes. I have about 7 or 8 scopes in my hospital, and that's why I still drive a Maruti, because all my money goes into the equipment that we buy. So I just about managed to get one Taigun. But trust us, and we have small theaters, but we have almost everything in the theater, whether it's a ligashore or a harmonic or an herbe. So you need to choose whether you want to buy a new iPhone or you want to buy a resectoscope. I think that's what you need to choose. So thank you very much for inviting me. One simple principle. Premium non nocere. This is what my teacher taught me. Do no harm. Be honest with your patient. There is a saying that says, know thyself. No matter what gas we give our patients, we know our capabilities. You know what you are capable of doing. And that's why I think workshops like this is going to teach you one extra thing. And it's all right if you have a septum and you don't know how to do it, call a master, see one, do one, teach one. That should be the principle. I'm going to not only talk about hysteroscopy, but going to talk about a few more complex reproductive tract anomalies. And fortunately, because Dr. Vaishali was kind enough to give me 45 minutes, nobody gives us more than 12 or 15 minutes these days, because they crowd the kind of workshop or the surgery. So reproductive tract malformations are rare in the general population, but are commonly encountered in women with infertility and recurrent pregnancy loss. Obstructive anomalies present around menarche cause extreme pain and adversely affecting the life of a young woman. Incidence 4 to 6% in infertility, 15 to 25% in recurrent pregnancy loss, 5.5 congenital uterine anomalies resulting from abnormal formation, fusion, resorption of the Mullerian duct. Of these, 8 are infertile, 13 will have a miscarriage, and about 24 will have fertility and miscarriage. Clinical symptoms and problems: anatomical distortions, which may range from congenital absence of vagina to complex defects in the lateral vertical fusion of the Mullerian duct system. Identification of symptoms and timely diagnosis are important key to the management of these defects. MRI and ultrasound are gold standards. In the puberty age group, MRI, we would be a little more partial towards doing MRI. Another thing that we've done at our center now is we tell the radiologist, I want MRI only for the uterus, I want MRI only for the ovaries, bring down the cost. We can get an MRI done even in Mumbai for 2,500 and 3,000 rupees. That's the kind of rapport. I don't take any cuts, that's why they can do it for that. So, three-dimensional ultrasound, surgical management depends upon the type of the anomaly, and knowledge of the genitourinary embryology is extremely essential in diagnosis of subsequent treatment. Just day before yesterday, I was doing a transvaginal sonography for an infertility patient who came to us as a new patient, and when I put the probe inside, I could see the kidney. So the patient had bilateral pelvic kidneys, horseshoe kidneys, and I had difficulty in getting to the ovaries. So second important thing, if you want to improve or increase your case load of hysteroscopy or laparoscopy, do your own ultrasound. That goes hand in hand with endoscopy. So this patient, I actually had to work her up, do a CT scan to find out KUB CT. Both uteruses are in the kidneys are in the pelvis just next to the ovaries. And I've seen in a situation where a TO mass has been removed and histopath came as pelvic kidney. So that can happen. I won't waste a lot of time on definitions and classifications. I think you guys can read about it on the books. Arcuate uterus, 32%, septate, biconvate, DS exposed, uniconvate, and uterine diadelphys. 94 observational studies, Mullerian defect anomalies, 5.5% of the general population. This is the 21 classification which we are supposed to follow, the ASRM classification. Cervical, Mullerian, uniconvate, diadelphys. Various ones, biconvate uterus, you can see serosal indentation of more than 1 centimeter, biconvate uterus. Septate uterus, the angle less than 90 and more than 1 centimeter here, or arcuate or normal, less than 1 centimeter of defect. So you can actually do an HSG properly and find out what the defect is like. On a transvaginal septum, and we'll probably try and show you all of these cases. Longitudinal vaginal septum, complex anomalies, we'll show you a couple of those as well. Mullerian agenesis, these are the 4 categories which you will get. Don't try taking pictures, it's all there in the books. What can it cause? Infertility, endometriosis, ectopic pregnancy, recurrent pregnancy loss, prematurity, IUGR, fetal malpositions. Like Dr. Krishnamar just showed you, she had a biconvate uterus, but she never realized that she had multiple children. Uterine dysfunction, rupture, increased perinatal morbidity and mortality. Very interestingly, presentation of puberty. Delayed puberty, primary amenorrhea, cyclical abdominal pain or cryptomenorrhea, painful menstruation, onset of menarche that progresses, worsens with time. Hymenal defects starts with the basic, the imperforate hymen, 1 in 2,000 females. Neglected cases will have hematocolpos, metra and salpinx. Surgery, simple cruciate incision is to be done. X-shaped incision, take catgut sutures to find out which are your margins. Take, say, 2 o'clock, 9 o'clock, 5 o'clock and 7 o'clock catgut sutures, so that you know these are your margins, because you will have to do a hymenoplasty at the end of it. I will just show you a video instead of talking about it. Where is my video going? Yeah, here it is. You can see this 10-year-old girl who had just attained menarche. MRI is showing a large hematocolpus. The uterus is right up there. And look at the video, very simple. All you need to do is take 4 catgut sutures on the sides so that you know which are your margins, and you're going to have to go back and suture that. You can see the entry points. And look at the amount of blood that is there, as you can see on the MRI. It's going to take a very long time for the entire thing to drain. But you need to mark your points so that you don't distort the anatomy of the girl. So once you've taken those 4 sutures, be gentle, use Babcock's forceps. You can use electrosurgery, or you can use just a simple scissor. As you can see, the sutures, 5 and 7 o'clock position, we've already taken. Use a cautery. We've started sucking with a small scissor, with a small this, and you can see the blood coming out. We actually drained 1 liter of blood from here. Can you imagine the kind of pain the small child must be going through? And at the end of it, you just need to suture, 3 o'clock, 9 o'clock, 5 o'clock, 7 o'clock, suture it again so that the area remains open. Keep a small mold with some sponge and holder there inside to keep the area patent. You can excise a part of it if you feel that the septum is very thick, and so that you can keep that area open. I don't think any hysteroscopy needs to be done at this stage. This is a young child. You don't want to do any of these procedures just because we have the hysteroscope. Let's go on to the next one. Congenital cervical agenesis. This is something that is rare, but today laparoscopic surgery has taught us that we can manage this laparoscopically. Very interesting case who came to us, almost married for a year, and the unfortunate part, or I don't know, irony of it, father-in-law is a general surgeon in the Middle East. Arabic patient, could not speak any Indian language, cyclical abdominal pain since 9 years of age. And she came to us at 25, history of 2 laparotomies for management of an ovarian cyst, 2012, and correction of agenesis. In fact, one of the referral letters that came to us from, because in Fortis we get a lot of these patients, it says that the surgeon had a giddiness spell and fell down, and that's why the surgery was abandoned. So I will show you that. So look at this, you can see a hematometra here. You can see a little absent cervix. You can see the uterus. There is no cervix, and there are small fibroids and adenomyomas. You can see here there is a large adenomyoma. Again, an MRI picture. On one side you can see this collection, which is probably a hydrosalpinx. MRI features, if you want to just go through it. Hematometra left, hydrosalpinx, adenomyosis, and a cystic collection in the vaginal apex. Operative laparoscopy was done. I will just show you the video. Because of 2 previous surgeries, she had a lot of adhesions. Again, harmonic is an excellent device when it comes to managing or doing these conservative surgeries. As you can see there, the uterus stuck, a bad hydrosalpinx on the left side. There you can see. We, of course, did not have consent to do a salpingectomy. She's young, 25 years of age, so we had to drain. Now, because of the previous surgeries and attempts at doing the repair, lot of adhesions, and on the MRI we knew there was a nodule very close to the bladder. So we are being very careful and gentle. You can see we are using the Urbe cautery to achieve hemostasis. Sharp dissection with harmonic or with scissors. The minute we went close to the bladder, that's the bladder you can see. We had taken consent that we may open the bladder because of previous surgeries and the adenomyotic nodule. You can see that adenomyotic fluid coming out. Mind you, she's 25 years of age. And as we went ahead, gauze is an excellent dissector again. At this stage, that nodule was there and we had the option of leaving it or incising it. So we decided to go in and incise that nodule. We injected some vasopressin there. You can see the nodule. And well aware that we were very, very close to the bladder. And as luck would have it, we did open the bladder. But fortunately, consent was taken. The nodule had to be excised for us to progress because we wanted to kind of incise the vagina. Obviously, this woman does not have a cervix. There you can see we've opened the bladder in a minute. That is the adenomyomatic nodule which is being excised. There, the bladder has been opened. We were ready. We just went ahead and sutured the bladder after achieving hemostasis. I won't waste time, just continuous 2-0 or 3-0 Vicryl, 2 layers of suturing, not very difficult. Again, we then made a vertical incision on the uterus, had very, very large adenomyomas which we had to resect. Remember, we have to connect the vagina to the uterus. There is no cervix. So then we did this adenomyomectomy. And then we were not progressing downwards after we did this because we needed to identify the vagina because of the previous surgeries. So it struck me, let us put a vaginal tube. So then once this was done, we removed the adenomyomas. We've reached to the lowermost part of the uterus. Then we put the vaginal tube. And that is when we could see the vagina. So we incised the vagina. That's the vaginal opening. We got the adenomyoma out through that. And then your job is to connect this uterus to the vagina so that at least she can menstruate properly. Conception can be an issue because there is no cervix, but she would at least be able to menstruate. So then again, 5 and 7 o'clock position, Prolene sutures, non-absorbable because you don't want that area to get absorbed and closed. Take Prolene sutures, there's, you can see taking Prolene sutures to fix that, and then close the defect with barbed sutures. And before you close the defect, put in a Foley's catheter into the uterine cavity. Don't distend it because of such a lot of pressure for such a long time. The Foley's catheter, if you distend it, it will cause atrophy of the endometrium. So we put in a silicone catheter, which we were supposed to remove after 6 weeks. That's the angle being sutured to the vagina. So the uterus is being connected to the vagina and the Foley's catheter will come out from the vagina. That's the Foley's catheter. And then the Foley's catheter shouldn't slip out. So we took a stitch on the fundus. Foley's catheter inside of the uterine wall and into the fundus, and we fixed it there. And then the entire defect was closed with barbed sutures. And of course, after that, we put a interseed there. Now, unfortunately for us, after 2 weeks, the catheter came out. Post-operatively, she was discharged on day 5. We wanted to keep the catheter in place. She had severe adenomyosis. So we were debating whether we should give her Dynogest, Leuprolide, or we should give her Ocipils because we wanted the endometrium to grow. So first we thought we'll put her on estrogen, but she was not tolerating the estrogen and no Indian language was known to her. We had to talk through an interpreter, and fortunately the father-in-law came in by then, who was a surgeon, and we could talk to him. Post-operatively, you can see here, the situation had improved a lot. You can actually see the triangular uterine surface on the MRI, but the catheter came out, and we did not want the catheter to come out. So there is no cervix. We wanted to do a hysteroscopy. So this is what we did. Again, the 2.8 millimeters sheath and the 1.9 millimeter, because we have that, we could actually negotiate. At least we were happy that the cavity is intact and we are inside. So we put on the Foleys again for the next 6 weeks. Today this patient is on Dynogest because of her adenomyosis, and she's not willing, because of the Ukraine war, she could not come for follow-up. So Krishna Kumar actually sent her to Osama for a follow-up. So anyway, so this is the notes which you said. If you read here, in the notes, as per the assistant surgeon, the operator decided not to continue the procedure when he saw the gap length closure was done. The operator felt unwell. So this is the kind of notes that we had from them. But anyway, as luck would have it, the patient is doing well and very, very happy that at least she is menstruating regularly. So trial of recanalization, she had undergone 2 laparotomies also in the past, one for a myomectomy. Second interesting patient again, the Overa syndrome, where you know there is half of the vagina which is obliterated. Again, a 10-year-old girl who was brought to us with a hematocolpos. You can see here on the MRI, large hematocolpos. And if you see this MRI here, you can see a uterus right up there. So again, the job is the same. We initially made a nick with the scissor to drain the fluid and then used the hysteroscope to cut that septum. You can see that initially we used a little monopolar cautery and then took the hysteroscope and went in. This is at Fortis Hospital, and unfortunately the Collins knife was not working, so we are using the resectoscope to cut that septum in the vagina. So we could actually get to the cervix, and you can see at the end of it, this is again a 10-year-old girl. We didn't want to do a lot of heroics. The vagina on the other side is large, well distended. Here you could see because of this obliterated vagina, the septum is quite rigid. And that's the laparoscopic picture. You can see biconate uterus, which is again a part of it, one-sided hydrosalpinx, which again reduced in size once the obliteration of the vagina was. You can see that left-sided hydrosalpinx. Typically you get hydrosalpinx on the left more often than the right in all these Mullerian defects. So again, this patient we had put in a silicone mold, and she came for follow-up for almost 2 months. This is not related to this subject, but another Iranian patient who was referred to us by a pediatric surgeon with ambiguous genitalia. This boy had uterus, tubes, ovaries, and undescended testis and a small penis. And the pediatric surgeon, after extensive counseling through a third party, came to a conclusion, Muslim family, that they want to raise the child as a boy, not as a girl. So they wanted us to do a hysterectomy on a 4-year-old child. So you can see here, there is a rudimentary uterus, ovaries, tubes, and a penis which has been catheterized by the pediatric surgeon. So we actually went ahead and did a hysterectomy because the pediatric surgeon was not confident of doing the hysterectomy. So this is another difficult situation where you can be. And this is the hysterectomy specimen where the ovaries were very, very large or normal and the uterus was extremely small. Yeah, true or right, yes. MRKH is another syndrome where you can actually get stuck. This is another interesting patient in which 25-year-old girl was referred to us for a vaginoplasty. And you could see that they said rudimentary uterus, hydrosalpinx on one side, absent vagina, but we went and put in the scope. If you can see here, she actually had MRKH with Cox. So what she had come to us for, we could not do because there was a lot of pus in the abdomen. I'm also going to rush through this because again, there you can see, Frank Cox. So we were mentally prepared to do a Macintosh, but we did not do it because obviously of this situation. And she's now on AKT, and this is the 9th month, and she's actually calling us every day to say, when are you going to do the vaginoplasty? Unicornate uterus, arrest of development of one of the Mullerian ducts. Sometimes when you have a very small cavity of unicornate uterus, we actually do a metroplasty. Okay, we've done a couple of patients if the cavity is very, very narrow. Here you can see, we've had 4 unicornate uteruses so far in which we've done IVF. Unfortunately, all of them have conceived. So this is another patient who was referred to us from Uttar Pradesh. You can see a rudimentary horn which is disconnected. Dye coming out on this side. Left side nothing. Right side, I'm so sorry. And that's the hysteroscopy picture. You can see those concentric rings as if there was an area of fibrosis. We actually took the hysteroscopy scissors and kind of opened up the cavity a little bit, and we are waiting to do IVF on her because she's been referred to us for IVF. KK, do you agree? Would you want to do something like this in a patient with a unicornate uterus? Thick, absolutely, absolutely. So that obviously is to be seen. You can see that fibrous tissue, which is, now if you cut normal cavity, it will bleed. You can see there is absolutely no bleeding here. So this is a patient in which, there you can see the cavity was actually a little roomy at the end of it. The uterus also looked a little bigger and better at the end of the procedure. So this is something that is also an option if the patient has been evaluated well. Another patient with a rudimentary horn with dysmenorrhea, not interested in fertility. You can see unicornate uterus with a rudimentary horn, complaining of severe cyclical pain. You can see here again those concentric rings, not interested in fertility, I'm coming back. So we had to kind of, on our MRI we saw that there was a little collection in the rudimentary horn. So either we had to go and remove this entire area. It's a young patient. So we made an attempt at hysteroscopy. We actually went ahead and resected that area and released the blood from there. We are entering the rudimentary horn. We have to be sure that you are in the right plane. And this Collins knife is a wonderful instrument. Gentle. And as you can see, blood coming out from that cavity. So this is why she was getting periodic dysmenorrhea. So this is something that is not very, very commonly seen or done, but I think we were lucky that we could do something like this and actually create a cavity from where she could drain a little bit of blood. Septate uterus, I think you all have seen an excellent septum being done by Dr. Krishna Kumar today. Definitions, normal or arcuate, you can see depth less than 1 centimeter, angle more than 90. Septate, more than 1.5 centimeter, angle less than 90. Biconjugate, the indentation is more than 1 centimeter. Again, this is an ASRM 2021 classification. Some studies still say that they don't believe in cutting the septum. This is a Cochrane review which said that RCTs are needed and that septum one need not operate, but a patient with septum will usually present with a recurrent pregnancy loss, will not present with an infertility. Again, these are various studies, and the conclusion that if a patient has recurrent pregnancy loss, I just saw a septum in an 11-year-old girl, which we were doing investigating for some, something else. My wife is a radiologist, and she did a 3D ultrasound. Obviously, you're going to leave it alone. Just brief the relatives a little bit. Don't be very aggressive when you talk to and counsel them. This is one septum which we have done, and you can see that large defect, which you probably obviously saw. Again, another complete septum. Whenever you see a flat uterus like this at laparoscopy, remember that this could be a septum. Yeah. So you could do this septectomy with scissors. You could use a monopolar knife, but we are very fond of the resectoscope, and we usually do our septums with the resectoscope. It takes hardly 5 or 10 minutes to do it. When my time is up, please let me know. I will stop. I have 20 minutes? Thank you. I'll finish by then. So beautiful cavity opening up. You could, in the past we used to put IUCD by removing the copper from it. Now we put a Foley's catheter and give them estrogen, progesterone. Unfortunately, as you can see, the cavity has changed beautifully. That flat uterus is now looking like a normal uterus. So this is something that you must also document. A complete septate uterus with a longitudinal vaginal septum. Again, laparoscopy, you can see a flat uterus. Again, like my assistants call it chapati uterus. And you can see this septum through and through. She was referred to as saying biconjugate uterus hai, kuch nahi ho sakta hai uska. Shaadi ho gayi hai, divorce hone wala hai. She was actually, because they had difficulty in having intercourse. So you can actually go in, use a regular open cautery and incise it till you reach the cervix. Even use scissors, identify both the cavities as we are doing with the scissor. cut the septum if you're running late and you want to go to Talegaon for a workshop. And once you reach the cervix, put in the resectoscope or a scissors and just go ahead and do the entire septectomy. Single stage procedure, does not have to be a two-stage procedure. There you can see the septum being cut. So either you can start from the fundus or you can start from the base. One of the two, whatever you are comfortable with, it can be done. And this patient had 3 children after this, and we actually managed to save her marriage. The cavity opens up beautifully. It's, I think, an extremely satisfying procedure. Your foot switch is what controls the current. That is very, very important. I've had a death with monopolar cautery 20 years ago when I was doing a TCRE. So I don't use any monopolar current anymore for the last 15 or 20 years. We have 2 underwater bipolar cauteries, one Allen, one Urbe. I think Dr. Krishna Kumar is a pioneer again in that, where he probably bought the first Urbe in India. But he's managed to buy a Mercedes. I'm still driving a Maruti. There you can see the cavity opening up. I think I call it endoscopy kida. You just look at something new and then you want to buy it. I don't want to go into the details. You all have seen a septum being done. Arcuate uterus, again, a procedure which is very, very controversial whether surgery should be done on this. We have done a few, but I will never forget one patient. I can still remember her name as Bharti Sayya, 8 previous abortions. And she only had an arcuate uterus. And out of frustration, we actually cut the arcuate uterus, and today she's got a 20-year-old child. One of the earliest arcuate uteruses. So if you've ruled out APLA, if you've ruled out thrombophilia, if you ruled out everything else, I think there is some justification to say many patients with an arcuate uterus will not experience any reproductive problems. But in RPL, I think it should be performed with a guarded prognosis. You must tell them that if I find nothing else, I'm going to operate. Not operate just because it's there. But a lot of endoscopy, hysteroscopic surgeons will, if they see an arcuate uterus at a primary diagnostic hysterolaparoscopy, they would probably go in and do it. Whether you want to do a normoscopy, diagnose, discharge summary पे लिखा है, uterus tubes normal, POD normal, bilateral spill plus, ovaries normal. I don't think we do any normoscopies anymore. I think ultrasound can pick up everything. HSG will pick up a tubal block. So most surgeries that we will operate laparoscopically for fertility is going to be an operative scopy. Hysteroscopic division of a subseptate or an arcuate uterus with miscarriage. This is an ACOG study which says that surgical correction may improve results. So if you've ruled out everything else in a patient with something like this who's desperate, I think there is some justification again. Arcuate uterus, very, very satisfying surgery again. You can just use a 2.8 millimeter sheath and a 1.8 millimeter scope. Go in with scissors, you could go in with a resectoscope, whatever you are comfortable with. And this is the video of that same patient I'm talking about. She actually has 2 daughters now. Not much to cut, just follow the ostium. Try and gauge how away that you are from the ostium. Say if this is the ostium, I'm going to go here and feel this. If I feel a resistance, I'm going to cut a little more. The minute you feel that the resectoscope is clearing very easily from the ostium to the fundus, stop cutting. Or reduce your pressures. If you see any blood coming out from one of the vessels, that's the end point of your surgery. So undercut instead of doing overcut, because there have been reports of perforation at 34 weeks of pregnancy also. So what we thought was very, very small actually is quite significant. You can see I'm feeling the ostium. And this is a fibrous area, so implantation, if that it takes place here, it's going to probably result in an abortion. That's the only logic that I can apply. And that's, you can see, that's the end of surgery. Bicornuate uterus, again, like they said, most patients will not realize that they have a bicornuate uterus. They will go through fertility. At the most, they have a preterm delivery, 34, 35 weeks. The Royal College also said that it can be treated. Initially, they should treat by laparotomy. Today, we treat it by laparoscopy. This, you can see a picture. Not my picture, not my surgery, but this is something that is possible. You can do this repair laparoscopically. Today, with the harmonic and barbed sutures, this surgery is just not very difficult. All you need to do is to get the bladder down, and you can have to identify that there is a single cervix. Bicornuate uterus can be repaired very, very easily. And hysteroscopic management of metroplasty. I think this is one of the most abused procedures today in endoscopic surgery with fertility surgeons and with this. This is a 24-year-old experience, and they said hysteroscopic enlargement of metroplasty is now a well-established technique with few complications, which should be nevertheless be reserved in symptomatic patients. Again, if patients are not conceiving. And the surgical approach to reproductive outcome after surgical correction, this is what they are saying. This is what you're going to ask your sonologist. Distance between the two ostia, length of the cavity, possible section in the width, safety margin. And we today ask our radiologist to pinpoint that and tell us. And this is what she tells us. Distance between the two ostia, 30.5 centimeters, length of the cavity, 3.8, possible section in the width, 8 millimeters, safety margin, 10 millimeters. So, you need to cut this. This is a justification that she's given you, or probably putting a gun on her shoulder and says, "Wo bol raha hai operation karne ko, main kya karu?" And that, but there is science behind it. So you can attempt a T-shaped uterus. If everything else has been ruled out, I come back to you and say, these are two procedures, arcuate and metroplasty. If you think that everything else has been ruled out, or at IVF you feel that the endometrium is not growing beyond 5 millimeters, I think this is one surgery which may help, though there is a lot of controversy to it. So you will do a little fundal metroplasty first, and then come back to the lateral walls. For those who use scissors, I think Dr. Krishna Kumar also uses scissors. I have some difficulty because I've broken a couple of scissors, because when I go do my lateral metroplasty, fundal metroplasty is very, very easy with the scissor. So we probably use the underwater bipolar cautery for that. Small, brisk cuts, brief, small, brisk. I think these are the three words that I will use. Don't put the foot, press the foot switch for a very long time, will perforate. So small bursts is what you want to do. There you can see the cavity pretty much enlarged. And medicine is a science of uncertainty and an art of probability. So if you create the probabilities, you'll probably make a lot of uncertain things certain. Thank you very much.
Yes, what a treat it was. Like to say something. So, we are open for question and answers.
I think I finished in time, 44. 2 minutes to spare. Thank you.
Anybody has questions? Yes. Dr. Vedpal.
Role of unification surgeries nowadays, sir. What is the role? You've shown one picture.
I haven't done any. Yeah, I haven't done any. There are people who are doing it. But like I said, in the era of IVF today, I think I have taken a unicornuate uterus with twins by doing IVF up to 34 weeks.
Yes.
The risk of perforation is going to be there, but if nothing works and the patient does not want IVF, a very remote role. But most often they won't need this unification. Most often they not justified.
Pregnancy rates have been good in true bicornuate uterus, 2 horns. They have been good, like close to normal uterus, even in IVF. So unification, you are cutting the whole myometrium right from cervix to fundus, and how much is going to be the adhesions which forms, how much is it going to be during obstetrics or during the pregnancy. It's all a very, very big question. Just because now people have, skill and the barb sutures have made it easy, so people are using it. But in no literature mentioned that it should be done.
Yes, it can be there. But if it's a biconjugate uterus, trust me, IVF she will conceive. I mean, touch wood, we've had 100% results with biconjugate uterus and fertility problems. They do conceive with IVF. So I don't think there's any reason why you should do a procedure like this. Unless the patient insists and does not want IVF and she's tried everything else and she doesn't conceive. Not something that I would want to do.
This infertility scoopy is like we incidentally we find biconjugate and you said some people do cut it, some leave it. What is it like?
Sir, there should be no by the way finding today. I don't think there is any role for by the way I found it. That's why I'm a great proponent of doing HSGs and 3D ultrasounds. They have to pick up.
Sonography will pick up. Sonography, good
HSG and sonography, a combination of two, will pick it up. But see, the point is that if you do a procedure on a patient who has not given you consent for a particular procedure, today you are liable to a problem. If I have seen a hydrosalpinx which was not diagnosed by HSG or ultrasound, I cannot delink that hydrosalpinx. I don't have the patient's consent for it. I have to do a salpingostomy. And that is why today I never do a laparoscopy in a fertility patient without an HSG. Never.
That's a small septum, yes, that can be missed. Of course, again, a good sonologist should have picked it up. But yes, see, you have to now classify sonologists also, those who want the gynec sonologist or the infertility sonologist are somebody different. I mean, there is a concept which is called coming as gyneconologist. Means not only this septum, they should know like multiple fibroid, the largest 7 centimeters, smallest 2 centimeters, nothing. It is not giving you any answer. Whereas you want fibroids to be mapped. Located on the anterior wall, intramural, something close to the endometrium, then it becomes easier. Again, endometriosis. They should be able to tell you adhesions in the pouch of Douglas, rectum. So that's why you have to identify a sonologist who can answer. You have to tell him that this is what during surgery I'll face problem. You just tell multiple fibroid. How am I going to counsel?
Best is do your own ultrasound.
So do map and then so tell them that you should map and draw me and send me. Rectovaginal endometriosis, see whether there are adhesions. So these gyneconologists have to be now tapped and they should be sent your all the references if you're sending them to.
Fertility endoscopy, like let it be diagnostic or operative, whatever. We are still at a diagnostic. So we take consent, like I find something like adhesions, distorted tube-ovarian relationship, like occasional endometriosis which was missed or something like this in the cavity.
See,
so can it be taken under blanket consent and then mentioned later?
There is no role for blanket consent anymore. There is a procedure-specific consent now. You cannot take a blanket consent and says diagnostic histoolaparoscopy, vagara, 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 vagara. It does not work. Foxy has come out with the 500 pages booklet on procedure-specific consent. Say if you say that you took a diagnostic histoolaparoscopy consent, you go ahead and do endometriosis, adhesiolysis, and you open the bowel, what are you going to do?
But then just diagnosing it and then leaving it and going for second set or something like that.
I think if you ask me today,
we still go through this type of things.
I do my own pervaginal examinations. My resident doctors do speculum, but I don't allow them to do the first PV. I do the first PV. Patient's bladder has to be empty. 9 on 10 times if there is endometriosis, you will feel that nodularity in the POD. I do my own ultrasound. Though my wife is a radiologist and I keep fighting with her. I have an ultrasound machine in my cabin. Next door she has a much bigger machine. She's a radiologist. So today now I'm tuned. We are in a cabin by the side of each other, and when the patient goes there, she will tell me, come, I want to show you something. And then this is how you coordinate. I'm lucky probably that I have my better half is a radiologist. But I don't think today out of 100 cases, in 99 cases we miss anything. That is the intensity with which you need to practice. Yes, you will still come across a surprise. I think Krishna Kumar does his own ultrasound.
Yeah, I also do. But in medical colleges, yes, you may be facing this more problem where you've not diagnosed something and after going in you find out. Yes. But in a private we do, even if we do, I'm not going to get money for it. Because patients say, you didn't tell me that I'm going to spend another 50,000 extra.
No,
so that's why you have to diagnose for both reasons, as you said, proper consent and also for the...
So basically,
you want to take.
I have seen a couple of centers, no HSG, diagnostic scopy किया, both tubes block, patient out, दूसरे दिन सुबह endoscopic surgeon वापस scope डाल के cannulation किया. because I cannot do cannulation. I have seen at least 50 patients like this. Today, one diagnostic-scopy, second day, operative scopy. I don't think there is any room for that today. So I think if you do HSG and ultrasound, 99% you will not miss anything. And on ultrasound, read the film, not the report.
Yeah, film,
Yes.
HSG, read the film, not the report. I don't look at the report.
All those answers coming from a true clinician, if I may add that
I am
comment,
an
sir.
unqualified laparoscopic surgeon today. I mean, I'm lucky because of stalwarts like this that today I've become the secretary. But by the time I finished my MD, I had not even put in a scope. This is my 30th year of practice. And what has taught me is these protocols. Gradually, one step at a time. You start with a diagnostic procedure, gradually grow to this stage. Today we do radical hysterectomies. I'm lucky that I do robotic surgery as well. Last year we did a robotic surgery, hysterectomy in a workshop which was organized by Dr. Krishna Kumar. So, if you counsel patients, if you investigate them properly, you will increase your caseload of diagnostic and operative laparoscopic surgery. If you don't do HSG, how will you get to find a septum? If you don't have facility for a 3D ultrasound or a tubal block. And unless you do your own tubal HSG, you will not get a case of tubal block. If you don't get a case of tubal block, how will you learn tubal cannulation?
So very important pointers those for these, especially the youngsters who are sitting in the audience. And the person who's doing the robotic surgery stresses on the importance of doing a per vaginal and per speculum examination himself. So do remember these take home.
Per speculum or per vaginal examination.
Unfortunately, sir, as teachers, we are seeing more and more this reluctance of putting in the speculum or putting.
Yeah, I've seen people straight away do with the TV. I said, don't put the probe inside, put your finger. That only a gynecologist can do a PS or a PV. Any other medical specialty cannot do. So you cannot lose that privilege.
So if you are residents, let me tell you, I have just recently seen one of my own ICU nurses who came to me for an antenatal checkup at 7 weeks of pregnancy, first antenatal checkup. I see my own patient's blood pressures and I put a stethoscope on the heart. And this girl working in a Fortis cardiac ICU had severe aortic stenosis. If I had let her pregnancy go through, it would have been catastrophic. So today we've done an MTP, now she's due for a balloon plasty of the mitral valve. So unless you are systematic, methodical, you will compromise on safety.
That's so heartening, sir. As a teacher, I would say, when we keep telling them that take the BP yourself, put a hand on the
because
pulse.
if you tell the sister, she will say 120/80 only.
Auscultate the heart. Don't jump to the per abdomen examination. I can't tell you what a moment it is for me as a teacher to hear that.
I have 4 MD residents in my hospital, and trust me, they have to go by the book. They have to actually go by the book. They have to, if the uterus post-delivery or post-cesarean is above the umbilicus, after a vaginal delivery it is above the umbilicus, she knows that she has to catheterize or get the ultrasound machine, see if the bladder is full or there are clots inside. Absolutely.
Yeah, fantastic. Are there any more questions? Sir has something to say.
We'll someday talk about management of critical care cases. I mean, we do a lot of critical care work in Fortis. We've done 21 accretas and percretas now. And I can demonstrate a internal ligation in 3 minutes. In 3 minutes. And the residents will do it and everybody can do it. I've done 26 independently now. 3 minutes on one side. Not a big deal at all. When I was the vice president last 2 years ago, that was one of my goals, but unfortunately because of COVID, I did everything on Zoom.
Internal iliac ligation or going retroperitoneum and safeguarding the ureter and learning hysteroscopy, every gynecologist has to do. You can't. We
save lives.
We were never doing it and we would always be reluctant to do a difficult case. But today with the advent of endoscopy and proper teaching, we see that why it is so simple. And as he said, he can do it in 3 minutes, 5 minutes. Only you should know the anatomy. We were always told to look away from the ureter. Now we run after the ureter.
Yes, absolutely.
We run after. Unless you run after, you won't safeguard it. If you look away, it is not going to go away. You are going to go near it.
Because the ureter is like your mother-in-law. पंगा किया तो जिंदगी भर परेशान करेगी. I say uterine is like father-in-law. एक बार बांध दिया चुप बैठेगा. But if ureter बांध दिया तो जिंदगी भर सताएगी.
I think as a gynecologist, we are seeing these anomalies, and luckily 9 months back I had a patient who had absent vagina and absent cervix with a normal size uterus, hematometra, endometriotic cyst and hematosalpinx on one side, and she was admitted at an institute for hysterectomy. Somehow 17-year-old girl, she had come from UP because her brother works here. And finally when she reached me, I was just inspecting, and the mother was insistent on just go ahead, do a hysterectomy, and we will be sending her to some place where she will just. I said, why? She is a 17-year-old, has a normal size uterus, so why not try something? So combined Macindo, laparoscopically removed the endometriotic cyst and the hematosalpinx on one side, and actually communicated the uterus to the vagina. 3 months kept the mold along with the silicone catheter, and 9 months now from the surgery she is menstruating properly. In fact, I had another lady, a girl in a periphery. I don't have records of that girl. She also had absent cervix and hematometra collection, and that time I was not doing laparoscopy there. Vaginally just did Macindo and communicated the uterus with vagina. 15 years from then, she is still menstruating. I had told the mother that about conception I cannot guarantee you. In fact, she was brought after 5 years by her mother for infertility. I told her, because she went to some other gynecologist who told there is no cervix. And in fact, it was just a conical thing and a pinpoint opening from where she still menstruates after 15 years. But I said, okay, at least if they are menstruating, they are having their femininity maintained and they are doing well.
Thank you, sir. If I may take the liberty of asking a few questions.
Sure.
If nobody has any, if there are, please welcome to ask. So in the hematometra case that you showed with the imperforate hymen, so the classic teaching always has been that, don't interfere with the blood which is collected inside, don't do any suction, all you do is put a cruciate and just let it drain. So does that not sit true anymore? Because what you demonstrated was taking the sutures and suctioning it out. And 1 liter, even I would be really thinking that it is better that we actively drain it out. So what would be the take today on this imperforate hymen situation, or does it differ from case to case, or?
See, most often this is a collection in the vagina.
Right.
And maybe a little bit of collection in the uterus. So if you just drain the vaginal part, the uterine part is left behind there. If you don't use a suction, she will probably get infected. And as you can see, most often they have endometriosis, they have hematosalpinx also. So as much as possible, I mean, today with the advent of ultrasound, now all these procedures, I would put my ultrasound probe and see. Put the abdominal probe and see. Do what is necessary.
Yeah, they said open it and don't touch that blood, because it is a huge culture media and the aseptic blood will become infected.
So you're most welcome to send it for culture. Take a swab and send it for culture. Find out what in 48 hours you get the report.
And would you also advocate putting a mold in every patient and doing a hymenoplasty, or?
See the basic, you don't need it. Basically it is to find out at the end of it where you want to cut and make your incision. The planning is this and this. So you want to cut between those two areas.
Right.
That's what it is. And this is taught to me by a pediatric surgeon, that she would take stay sutures and just approximate that area there, because you don't want that thing to close again.
So would you advocate something like reefing?
Yeah, basically it's a 10-year-old child, and you can't go in,
Yeah.
you can't go in again and again and
Agreed,
manipulate
absolutely.
that child. So you need to be safe. And once that mold is there, it just doesn't allow it to close till those sutures heal 5, 6, 7 days, I think. And the remaining blood also hopefully will come out. If you've not reached and removed everything, if that area is patent, the rest of the blood will come out from it.
And the second question was pertaining to the lady. Of course, she had too much of adenomyotic nodules, the one with the absent cervix. So, of course, this was different because you needed to go in laparoscopically for very many reasons and then take out those if it were the virgin surgery which you were doing for the first time with a diagnosis of an absent cervix, would you advise any attempt from the vaginal route with a laparoscope for guidance, or do you think?
Cervix, how will you go vagina? You have to connect the uterus to the vagina, and see, if you don't do it laparoscopically, if say this is the uterus and this is the closed vagina. Sorry. Yeah. So if this is the uterus and this is the vagina, if I go from here, I may go left, I may go right. So when I put that, see, even till we put the vaginal tube, we did not know where to incise. So only when we put the vaginal tube is when we saw that area, okay, this is where I'm going to cut. It has to align perfectly. The lower segment of the uterus and the vagina have to align properly. And that's why we needed some guidance, and that's when it struck me, let's put the vaginal tube. This is not something that we have planned. So that's when I think going laparoscopically, opening up the anterior abdomen, the anterior wall of the uterus, and then connecting it there makes a little more sense. Nothing in these cases is pre-planned. You have to just kind of think.
Yeah, we had some experience. I personally was called once that they were blindly kind of digging here and there. Of course, we ended up, there was no arrangement for scopy, so we ended up opening the patient. There was.
So this is the third surgery I'm doing on this patient. She had already attended, had 2 failed attempts in the past. I didn't fall and felt giddy, fortunately. But
And we loved the honesty with which Sir opened the bladder and showed it to us. Another lesson to be learned, which even
I will show you all my complications.
Which Dr. Manish Machwe was trying to stress upon, that, there will be complications, show them, also show how you dealt with them. So the upcoming lot then does not fear these things.
Never ever lie in your discharge summary. Never. If you perforated right, you perforated. I can show you, I can take another lecture on complications in lap surgery, and we will show you all the complications that we've managed. So never lie on the discharge card, because I told you, I've gone to court 4 times. In one of the patients, the wife sued the husband and me for having done a DNC for 6 months amenorrhea. And she was kind of asked to go, she underwent a divorce because the husband's filed a case of divorce saying that she can't conceive. This is a patient with primary amenorrhea with an FSH of 50. I had in my indoor notes her HSG, her ultrasound findings, which was done just 2 days before the surgery, and her FSH level, which said that the FSH was this much. And because she was not getting a withdrawal, we did a hysteroscopy. That's what saved me. This is in High Court. So I've gone to court also for having done a DNC and a patient who died 6 months later of 2 grams hemoglobin and sepsis. And the main story was that she had a huge LIC on her name, and the mother and the husband were fighting, and the mother put the husband in jail. And this was a DNC we had done for incomplete abortion. So what saved me? I had the mother's consent, I had the ultrasound findings and the hemoglobin findings, which that said hemoglobin was 8 grams. So, be honest, every discharge card that you give the patient, the Xerox copy should be in your indoor file. Every discharge card.
Discharge card is the most important document which you are giving to the patient. You can never change. Other indoor paper, everything you can change, but what you handed, that's it. You cannot change it.
I have gone to court, I was taken to courts, rather, for a patient committing suicide for white discharge. That's what the defense lawyer said, that she was so fed up of the white discharge that she committed suicide. I had my cultures in place. We had taken cultures, we had treated, which also showed no growth at the end of it. Basically, this was mother-in-law, daughter-in-law fight, and then she committed suicide for whatever reasons, but I was taken to court. And the defense lawyer also asked me, sir, आप बोलो कि ये white discharge इतना तकलीफ दे सकता है कि वो suicide कर सकती है? And I said, no.
25% of women will have to die then.
And at the end of it, and this was one very, very famous criminal lawyer, Ponda, in Mumbai, and the judge actually finally told him, you are trying to pressurize, he's the expert, not you. White discharge, आप दवाई कर रहे हो कि वो दवाई कर रहे हैं? So I think your notes, your examination findings, moral of the story is, your discharge summaries tell you everything. They are the mirror of your treatment. Once the patient takes that file outside, that is the mirror of your treatment.
Another heartening point for a teacher where the residents are most reluctant to fill in the discharge cards, that don't take the discharge card lightly, don't pass it down to the junior most on the rung. When I tell her and she tells him and he tells her.
Without dates, discharge card, only some medicines written, surgery done, medicines written, no operative notes, no surgery name, just one date, date of admission written, date of discharge not written. And all those discharge cards, I can all, show you everything like that. But that is today we are in a medical legal world. Patient will take you to court at the drop of the hat. So I think that part, nobody can escape. And now I think we are in era of computers. I mean, today I don't use any paper in my discharge card. I only use my tabs. So we are completely paperless for the last couple of years. The entire discharge summary, the entire indoor papers are in the tab on the cloud. So you can edit them.
Okay. Thank you so much, sir. What an interesting session it has been, and we are so privileged to have masters and people who are so sound. I'm going on saying that sentence again and again, but I can't tell you how happy it makes me as a teacher to hear you reiterate what we try to teach every single day in the OPD and in the wards. It's wonderful when it is reinforced by masters of the trade, if I may say so, of the art is what it really is. So thank you so much for a beautiful session, and it was a great treat to see sir operate. With that, we'll come to the valedictory function, and we're just waiting for our executive director. And I have announced it before. If there's anybody who has not filled in the feedback form, the QR code is displayed both on the paper program details which is there in your kit, as well as it's displayed outside the venue at various locations. Do fill in the feedback form so that you will be able to get the certificate of participation. So if anybody has forgotten to fill it yet, do fill in the feedback form. So our executive director will be here in a few moments. We welcome our principal, Dr. Swati Belsare, who's been kind enough to already occupy the hall, and we'll be starting with a valedictory function in a moment. If there are any more take-home messages which you would like to tell us as teachers, sir, we've heard enough for the students. If there's anything which I should, as a postgraduate and undergraduate teacher, know, I'd really love to hear it from you.
No, I must congratulate your idea of having this hysteroscopy masterclass here. And of course, today afternoon, Gopal Gare was telling me that they have the laparoscope, everybody is doing laparoscopy, they don't have the hysteroscope, they're not doing hysteroscopy. So I think you can't avoid doing hysteroscopy. So maybe, of course, the strategy is, of course, you all are having as a medical college, at least you're doing laparoscopy, because there is a wide gap between the teaching in a medical college for gynecology and what is being practiced outside the world. So every candidate who passes out has to spend at least another 2 or 3 years learning the skill of doing, because they cannot do open outside, because we all are doing 95% endoscopic, only where indicated sometime we have to do open up. So that gap at least you are having. Laparoscopy, your residents and your others subordinates do. So that is definitely really commendable. But somehow I think hysteroscopy has to be brought into the medical college and has to be inculcated. So you very rightly told me that not only the students, even the faculty wants to learn.
Absolutely.
So that is where, so that is why I said I was more than happy to come and definitely to. And after I finished my IAG presidentship, I have been doing, this is the second hysteroscopy master class. Nasik I did 16, 17, which I did 12 surgeries, again here. So I'm sure the people are now getting into the mood of doing hysteroscopy. So somehow you have to see whether you can procure the hysteroscopy set.
The conversation is going on at
The exact time when our executive director has
I
entered
didn't
the
know.
venue.
He was quite young, so I'm sure.
So we were just like kind of giving
I thought he's one of the delegates who is coming. He's quite young. Sorry, sir.
I was like, bolte
Yeah, but I
jayenge,
didn't
bolte.
tell anything. You pressurize them. I said you should motivate. You should see that you
So
get
now,
it.
sir, positively in next 10
Because
months, we will be having.
I have shown that gynecology is, without hysteroscopy, you are half baking your own students, outside, which is unfair. Which is unfair for them. I know the difficulties which the medical colleges are facing, but somewhere that has to change. When the teaching has to change. So hysteroscopy is going to be something which has to be, I think, brought in a big way to everybody, every gynecologist.
From his expressions, he is totally convinced.
Thank you so much, sir. May I?
We can still read his eyes.
May I request the dignitaries to please occupy the dais. The dignitaries are our chief guest, Dr. Krishna Kumar, our guest of honor, Dr. Atul Ganathra, our executive director, Dr. Virendra Gaisas, and our principal, Dr. Swati Belsare, and our very own head of department and chairperson, organizing chairperson for the conference, Dr. Vaishali Korde, madam. Thank you so much for gracing the dais. As is the tradition with all our programs in the entire MIRS group of institutions, we start with the auspicious World Peace Prayer. May I request all to please rise in your places, fold your hands, remember your mother, father and your guru, and let us all join together to pray for world peace.
Guru Brahma, Guru Vishnu, Gurudeva Maheshwara, Guru Sakshat Parabrahma, Tasmai Shri Gurave Namaha. पूर्णमिदं पूर्णात् पूर्णमुदच्यते पूर्णश्च पूर्णमादाय पूर्णमेवावशिष्यते ॐ शान्ति शान्ति शान्तिः हरि ईशावास्यमिदं सर्वं यत्किञ्च जगत्यां जगत् तेन त्यक्तेन भुञ्जीथाः मा बुधः कश्चिश्विद्धनम् ॐ भूर्भुवस्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो न प्रचोदयात् सर्वेऽपि सुखिनः सन्तु सर्वे सन्तु निरामयाः सर्वे भद्राणि पश्यन्तु मा कश्चित् दुःखमाप्नुयात्। शान्ति अंतरिक्ष शांति पृथ्वी शांति आपशांति औषधय शांति वनस्पतय शांति विश्वदेवा शांति ब्रह्म शांति सर्व शांति शांतिरेव शांति सामा शांतिरेधि ओम शांति शांति शांति.
Thank you, everybody. Please be seated. So this 2-day masterclass on hysteroscopy, which we all have been lucky and privileged to have been part of, was started with what Mimar Medical College and the Department of Obstetrics and Gynecology believes in, is to always strive for excellence and not stay within the framework of what is to be done within the curriculum or must do or what MUHS says or what NMC says. And we have been really lucky to have heard great speakers yesterday, sir, who spoke on the very basics, like what are the basics of the trolley of the hysteroscopy, then the medico-legal aspects and complications of hysteroscopy. And we had a panel, very interesting one, in which we could see that there was a plethora of heterogeneous minds which could come together on a platform. And the audience has been an excellent one. They kept coming up with a lot of questions. So it was a very interesting day yesterday. And today, well, everybody will agree what a treat it has been to see live surgery. And we are so, so lucky to have such a great master come right down to our premises and show us live surgery. I don't know who's luckier, the patients, we as a department, you as the audience, or Mimar Medical College campus. And the secretary IAG, the videos which sir showed, the knowledge points which he gave, they are like gems to be preserved forever. With that, we'll move on to a few acknowledgements of people who have been with us for in different capacities. May I request our Executive Director to please felicitate Dr. Shemwalekar, who has been kind enough to manage the auditorium end while the live surgeries was going on. Thank you so much, sir, for keeping that entire live surgery so very interesting. Thank you so much, sir. It's as important that the audience point of view be conveyed to the operating surgeon. Thank you so much. We next move on to Dr. Dattatreya Gopalkare, our very own professor who has been the MMC observer. May I request sir to please give him a token of appreciation from our side. He's the MMC observer for the conference. Thank you so much, sir. Is Dr. Shilpa gone? Okay, so we wanted to also give a small token of thanks to the head of anesthesia department to acknowledge the immense contribution of her team. All right. It's now my great privilege to introduce Dr. Atul Ganatra. I don't know how I introduce him after he has shown what he is to all of you by his talk, by his knowledge, by the surgical videos that sir showed. Nevertheless, let me tell you that sir is the director of Ganatra Nursing Home and the Progeny IVF Center. Sir is a consultant obstetrician, gynecologist and an endoscopist at Fortis Hospital and Jupiter Hospital at Mumbai. Sir is currently the secretary IAGE. Sir was the vice president FOGSI from the year 2020-2021. Sir has been the chairperson of the MTP committee of FOGSI for the 2 years from 2012 to 2014. Sir is a member of the managing committee of MOGS, and Sir is on the medical advisory panel of the Family Planning Association of India. May I request our executive director to please felicitate Dr. Atul Ganatra. A big round of applause for this wonderful person who has been part of our workshop. May I now request Dr. Ganatra sir to please let us know what are his thoughts about this workshop. So a few words from you, sir, about this workshop.
Thanks very much, first of all, for inviting me, and we love teaching. I think I would say teaching ka keeda hai humko, and I have come up in a very difficult way. I did not do my MBBS or MD from Mumbai, and I was told कि तेरा कुछ नहीं हो सकता. This is 30 years ago, and I said नहीं, इसको दिखाना तो पड़ेगा. So it's where you come from. It doesn't matter what you do, how you progress. It what matters. And between Krishna Kumar, myself, Bhaskar is the president, Dr. Pandit Palaskar, we want to teach. I'll tell you a simple story. When I did my first day of internship in the medical college, and I went to the emergency room with a Littmann stethoscope and a white coat, there was this brother whose name was Kazi Bhai. He was a male nurse, and there was a patient with asthma who came in and needed an IV line, and I could not get that IV line. And Kazi Bhai told me, Doctor Sahab, स्टेथोस्कोप पहनने से कोई डॉक्टर नहीं बनता है, घिसाना पड़ता है. MBBS करने से IV लाइन लगाना आ जाएगा, ऐसा नहीं है. So even today, and that time there were no cannulas, scalp veins, and we used to carry cannulas in our pockets for our bad patients. And that day I said that none of my other resident doctors will face this, and I actually spent 18 hours for 1 year in the hospital. I would go home only to sleep and to change. And today I can teach right from an IV line to how to put a Foley's catheter, and I'll tell you, I will show you how a Foley's catheter is to be put with aseptic precautions. These are some basics that I teach my residents. And I think that's what we want to do in endoscopic surgery. We have this position which is a responsible position, and our job is to teach, show one, teach one, and let you do one. Obviously, we will not let you do complex cases, but you have to grow. I have also started doing a diagnostic scopy. I had not put in a trocar till I finished my MD, and I don't want you guys to do that. And that's why we are here. It's less than, क्या बोलते हो, मौलाना मस्जिद के पास जाएगा तो मस्जिद आपके पास आएगी. That's what we want to do, and we will travel, and we are willing to travel. Thank you so much.
Thank you so much, sir. The gynecologists of this country are in good hands with responsible members like you, and my heart swells as a teacher to hear you say those things about wanting to teach and how every resident should be taught so many things, and so much to learn from personalities like sir. Moving on to our boss, Dr. Krishna Kumar. Dr. Krishna Kumar is the Director and Chief Consultant of JK Women Hospital. This is a NABH accredited hospital in Mumbai, that is in Dombivli. Sir is also a consultant at Fortis Hospital. Sir was the immediate past president of IAGE. He was the Honorary Secretary General of the Indian Society of Assisted Reproduction, that is ESAR. All the gynacs must be knowing that. Sir is an ISHRE certified reproductive endoscopic surgeon. Sir won the Dhanvantri Award for Maharashtra in 2015. Sir was awarded by the National IMA. He was awarded for being among the eminent men with distinguished achievements of the highest order during the year 2020. So center is recognized for a 6-month certification course in endoscopic surgery and infertility by ICOG. So has organized several workshops in endoscopic surgery. So also has the credit of conducting an international workshop on hysteroscopic surgery under the banner of the American Association of Gynec Laparoscopy. People who, and sir was just showing us, Dr. Viren sir, before you came, about his upcoming international certified course in his center in coming June. This had several faculties and delegates who came in from across the globe. Sir, of course, we all know, has been invited as a faculty in various national and international conferences, mostly on infertility and endoscopic surgery. So has written so many articles in various journals as well as in textbooks. Not just the person, but his center also has won several papers and awards in various MOGS, FOGSI, AICG conferences for 4 consecutive years, or has won the best paper on endoscopic surgery at MOGS in 2013, 14, 15, 16, 18, 21, at all these annual conferences. So it is a moment of pride for us to have you here. May I request our Executive Director to please felicitate Dr. Krishna Kumar sir. Maimur is really blessed to have you, sir. May I call upon Dr. Krishna Kumar sir to please come over to the podium and express his thoughts on these 2 days of workshop.
I didn't come for the workshop. It was like second homecoming to me here. You would wonder why. Because of my son being a student from here. He did his MD Gynec, and Dr. Vaishali Kurde was his teacher. So I remember the day when I came about maybe 10 or 12 years back, when I met Dr. Sushma for the first time. I wanted to just come and see how the department is, and I must really appreciate what I saw at that time and what you have progressed. It shows your eagerness, your desire to give best to your students. And of course, both of you were almost like second mother to Rohan, though of course she did tell me that a lot of other mischief and which she didn't want to tell me, but they are still in good touch and they are communicate whatever good and bad, they are still in touch. So that was the kindness which she has, and that is a very rare thing for a MD postgraduate teacher to be involved with a student of or that at that age. So it was a real, not just honor, it was my definitely the luck that I was called here as faculty and I had to agree. So there was no second thought. So I'm happy that I came here. And as I already said, this has been after my IG presidency where the load was too much. I was doing all of other work. But after that, people are calling me for more and more hysteroscopy workshops and teaching. And of course, I love teaching, as Dr. Atul Ganatra already said, that we all love teaching. And I must thank both the president, Dr. Bhaskar Pal and Atul, that I sometimes feel whether I'm still the president of IIG because I'm getting more importance than what they are doing, I feel. So, which I don't want to, but the way they have been giving me, you do this, as if I'm the boss here. So I must really thank them for giving me all the importance. But as he rightly said that he was not from Bombay and he said, Tera kuch nahi hoga, but you were far better. I don't think you have to really crib about it. Being in Bombay also, we had felt about 35 years back, apna kuch nahi hoga. Because those days only KEM and Wadia were in the limelight in gynecology. Every teacher, every conference, only they will speak and we all had to just listen and as if we are too inferior. So that was the desire we wanted to prove. And today, the world is open because the teaching is so simple, learning is so simple, you don't need somebody standing on the podium to really teach you. You can learn everything. But it is important that medical colleges teaching is important. We cannot ignore like what people have done in the 12th standard, never attend the college but only crack the NEET and only go to the NEET class. So such thing cannot be possible in a medical institute. So there the medical college respect has to be maintained, and I'm happy that the professors of the department is really taking keen interest on teaching modern things or the newer things in their own speciality. So from that point it is really commendable. But even associations are important. Today any individual can showcase his talent through whatever way he want, but the recognition will come only if you are associated with either a teaching college or an association. Definitely the growth will be much better, faster. So you must respect this point, that definitely you have to be either way. Learn, keep learning. Learning never ends. We are still learning. We are staying apart from, of course, the more you teach, the more you learn. Unless you teach, you are not going to, at this stage when we are in private practice, we will just become defunct if you don't teach. You have to learn to teach. So that's what keeps us going. And we have grown, and I must really admit that after getting into an association like IAG, we have grown tremendously. Of course, learning those days endoscopic surgery was very difficult, 20 years back when we started. But today it is easy, but stick to the principle, nobody can be inferior to the others. Everybody can be equal. You have to just follow those basic principles. So I thank once again that I was called here, and I'm sure I have motivated you all to some extent to do safe and proper hysteroscopic surgery, and will continue to do that and follow the IAG. And I must also thank the organizer here that they got associated with IAG, and we all want to conduct so many courses of CISAS masterclasses across India, which is all coming up now. So this is the first of the IAG masterclass for the present term. So, and I am happy that Atul came all the way from Bombay in spite of difficulties and his emergency. Is a very, you could have seen so many, is such a busy person, but a very versatile person. He has been helping me even in when I was the president, and he continues. We continue to interact for the association, and we are straightforward, and as he said, all of us are interested in simple teaching. No air aura about it. Learn the basic, teach the basics, and make everybody happy. Thank you.
Thank you so much, sir. It's stalwarts like you and pioneers like Ganatra sir and you who try to make sure that the new youngsters don't feel tumhara kya hoga, tumhara kuch nahi ho sakta. So thank you for all that hand-holding, sir, and the department definitely looks forward to more association with the IAG and to maybe taking it forward in very many different ways. Next, may I call upon somebody who is not just a management person, but an academician of his own right, who's a teacher, who's an author, who has an international name in his own field, in the field of rhinoplasty, and who keeps motivating us, and we learn so much from a dynamic person like him, Dr. Virendra Gaisas, to please share a few of his thoughts about this workshop.
Thank you, Dr. Sushma. Respected Dr. Ganatra sir, Dr. Krishna Kumar sir, Principal Madam, HOD Dr. Korde, Sushma, Gopal Ghare, Pawar sir, I think everybody, sir, Dr. Gupta sir. I think first of all, congratulations for a successful live surgery workshop. Live surgery workshop nowadays is of great importance in many aspects. I was just talking with my ENT postgraduate students. So I was just telling them, and I think sir also reminded me the same. After passing my MS, or when I was doing my MS, how many rhinoplasties I have done that time? The number is 0. How many stapedectomy I have done during my post-graduation? The number is 0. Because the audiovisual that time, or the surgeries given that time by the professors were entirely different than what we are doing now. So now for new postgraduate people, I think the audiovisual, the YouTube, it's so nice. You will see all the surgeries, so many live surgeries happening. So it's no way that you know, it's like professor ne ye sikhaya nahi. No, I think it won't happen because of this new technology. I'm not saying that you learn from YouTube, no doubt. You have to have great teachers standing behind you. But now you cannot hide the things from postgraduate students the way it was there our time. So I think these live surgeries are part and parcel of our postgraduate and even after that, a part of our curriculum. It's not only the surgeries, what you see how the surgeon is standing, as she said, how is the trolley is made. You know, these small things, how is the personality, how is this guy, why this Dr. Krishna Kumar is great. Is it just because he is great, just because he is surgically nice? Or it's something nice in his personality? Same is Dr. Vid Ganatra. I can, in 5 minutes you will come to know he's down to earth, straight. So it's not Vidya Vinayana Shobhate. It has to be, on the ground. It's not the Vidya, it's only the surgical skill great, but the very arrogant and useless surgeon or as a person, he won't do great in his career. So why these great faculties are really great? It's not just because of their surgical skills, it's something else too. And during live surgery, you should learn what is this something else also. So that is the same thing what the Maimer is also talking about, is the ethical doctors, it's the ethical practice. It's not the engineers, the great engineers, Mair as an institute we want to produce, or just a doctors in a numbers. It has to be an ethical engineer, it has to be ethical doctor. So it's not the only doctors, it has to be ethics. So that's what our institution stands for, and that's what you should see in these great faculties. So to sir, please do come back again and again. So we want to have your company, and I'm sure they will produce such a event again, so that they will form a platform again, so that you can come back here and teach our students and everyone. Lastly, I think it's a taunt to the professor and the head. I think anesthesia department is there, they have got all draggers. The surgery department is there, they have harmonic scalpel. So I think you should ask for the instruments, you will get it. So why you have not got it is because you have not asked for it, right? So okay, yeah, thank you so much.
Thank you from the management for that reassurance, sir. Immediately you'll get the requisition. And yes, may I let everybody know that Maimer does stand for value-based medical education, which is the thing which comes from a very founder president, Dr. Vishwanath Karad, sir. I see the head of department anesthesia may take this opportunity to give a small... Huh? क्या बोल रही है? Okay, right. So now I'll move on to our very own Dr. Vaishali Kurde Nayak, our professor and head and the organizing chairperson. May I invite her on the podium to give away the vote of thanks.
Thank you, Sushma. Yesterday in the same hall at inauguration, when Dr. Dilip Kamath sir and Dr. Sanjeev Khurd were our chief guest and guest of honor, we all were very much overwhelmed with joy to have them coming to this campus and give blessings to this masterclass. Today we all are like full of satisfaction. The day what we have seen, the surgeries which the way they have been demonstrated, and the lectures which happened in the afternoon, we all are really the academic satiety we have got. So, respected dignitaries on the dais and off the dais, we all are really full of academics now and full of enthusiasm to start a operative hysteroscopic unit in Maimer very soon. For this masterclass to be successful, we have to thank few people, because it is in association with IIG, and as sir said, when it is associated with institute like medical college and IIG, definitely the standard of that program gets up, and definitely it has more validity. So I'm really grateful to Dr. S. Krishnakumaran sir, who has agreed to come all the way from Bombay for this workshop, spend the whole day with us. Sir must have started early morning 6 a.m. with his assistant, with all the instruments, with his fellow, coming all the way, demonstrating the surgeries in a foreign OT, and then teaching us every small practical tip which he gave today will stay with every one of us forever. And then sharing his presentation with us. Sir, we cannot thank you enough. Thank you so much for all the support which you always show, and more so for me. You are a parent of my PG, but coming all the way after 7 years of him leaving the institute and saying those words mattered a lot to me. Thank you so much for that. I can't thank enough Dr. Atul Ganatra sir, who's Secretary IAG. Associating with IAG is again a dream, and it's first ever in his tenure. It is the first masterclass which we are having. Sir has obstetric emergency. He has not slept the whole night. Still, he is so committed that he came down. He got stuck in traffic in Apla Road Expressway Madhe, Ghata Madhe. Still, he came down, and the excellent presentation and the videos which he had shown has made our day. And we know the tips. It was basically hysteroscopy masterclass, but sir had given us many tips and medico-legal advices also from the discharge card and all those things. And sir, we are really grateful to you for all those additional things, and thank you so much. All the faculty, 3 of them yesterday who had given the deliberations, Dr. Manish Matswe, who was chairperson Foxy Medical Legal Committee, Dr. Nilesh Balkavade, who had given us an overview about infertility, who is again chairperson Foxy Quiz Committee, and Dr. Pankaj, who is our alumni, who is again a very renowned endoscopist in Pune and Nagar. So all those lectures were excellent, and they gave an excellent theoretical knowledge, and today, this day, we have seen the completion of the total masterclass with yesterday's afternoon session having a histo trainer, and all the delegates could learn on the histo trainer, and Dr. Manish was there till 5 p.m. teaching all the students that what should be their approach, and it was really grateful, and we are thankful to them. We are also thankful to our today's moderator, Dr. Kundan Ingle, who is sitting chairperson of Infertility Committee. He was here, and the live interaction was very useful for all the delegates, and also Dr. Shelmorkar, who had been conversing with the OT people throughout the day. It was really very interactive and very informative. Thank you so much, sir, for all that, all those efforts. Now coming to our own management, Mimer, our executive directors are all very supportive. Sir, he looks like a young delegate, but he is a world-renowned rhinoplasty surgeon. He has our inspiration because maybe 7-8 years before he has started live surgical relay in this campus when it was a very new thing. 2009. Since then, he is having his live interaction and live surgical relays, and he is really an inspiration to Mimer. We have been doing programs with POGS otherwise, but in doing it in Mimer, he is the pioneer of it, and the credit goes to him. And whenever we decide to do such things, he is always very supportive. And now hysteroscopy unit is just coming to Mimer, so nothing like it. We are very grateful to you, sir, and to even our other executive director, Dr. Suchitra Nagre ma'am. Principal madam had supported and guided us for designing this masterclass and making it again NAC important. So thank you so much, ma'am, for all your inputs. We have received a lot of help from all the departments, and first and foremost, I would like to thank our MMC observer, Dr. Gopal Ghare sir, for being so kind and playing the dual role of arranging it, having the surgery, running around, and also observing the conference and giving us 4 points and 6 ICOG. 6 ICOG points as well we have got. So we are thankful to MMC and ICOG both. OT team, Bosle sister, excellent cooperation, and we are really grateful for all that arrangement. If OT sister is here, we would like to felicitate her. Department of Anesthesia and Dr. Shilpa Gurav, HOD, I request you to please come forward. I request Dr. Virendra Gesar sir to please, I request Principal Belsare Madam to please felicitate Dr. Shilpa for her team and all the efforts. Any masterclass is incomplete without financial support, and we have even instruments which are very important part of such kind of live surgical workshops. And we have Mr. Sandeep from stores. I request him to please come forward, and I request Madam to please felicitate him on behalf of Mimar. Thank you so much. Because of your help, we could run both the OTs simultaneously. Mr. Mukund Joshi from Akino, if he is around. Mr. Mukund Joshi has left probably. I request Om Surgicals, they are here. Please join us. Mr. Shailesh, right? Yeah, please come, and I request Principal Madam to please felicitate him. Thank you so much. Mr. Hari Wagmare from Sun Pharma, please come forward. Sun Pharma has been gracious enough to give us a good sponsorship for this masterclass, and Mimar is definitely very thankful to you. Prashant from Digital Info, the relay was absolutely flawless, and all the audience, you can see the smiling faces. Sir was excellent, but the way you relayed and the way very smoothly it went on, thank you so much. Thank you. Suhas, we thank you for the good food. Yes, ma'am, it's done. Please come. And all the supportive department, maintenance, Ashwini, Mitkari for photography, Rohit, thank you so much. And we are really grateful. And most importantly, OBGY department, who has put in lots of efforts, collected nice cases and proper precise execution. Thank you so much, friends, for all the efforts put in, and the delegates. Till 5 p.m. you are sitting and enjoying this show, and we promise you that Mimar would come back to you again with a great program like this again. So thank you so much for attending. Thank you.
Thank you. And we end with the 9 verses of the Pasaidan. It said that just mere listening to the Pasaidan also showers us with the blessings of the Almighty.
ईश्वर निष्ठांची मांदियाळी अनवरत भूमंडळी भेट तू भूताला चला कल्पतरुंचे यारह चेतना चिंतामणी के गाव बोलते दे अर्णव पीयूषा श्रीलोकी दृष्टादृष्टविजये होमावेदि एकमने श्री विश्वेश्वराय आहो दान पसारो ये हरे ज्ञान देवो सुखिया
Thank you, everybody. Thank you all for coming. Do join for tea and coffee, which is served right outside. Thank you, dignitaries. Please do join us for tea. And the delegates, your certificates are ready. Our team will just confirm that you have filled in the feedback form, and you can collect your certificates from the desk outside. Thank you so much. Have a great evening ahead. Request Department of OBGY to please stand in for a group photograph. May I request all the members of Department OBGY to please come forward to the dais. Principal Madam, please, one photo. Ma'am, one photo, then you can. Please, OBGY members, please step forward immediately so that we can have a photo.
चलो आ जाओ फटाफट सब थोड़ा सा इधर जाओ
Last